Hello, 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 my friends. Let's see. YouTube is live. Is Facebook live? Not yet. Hold on. Yes, Facebook is live. Hello, 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 my friends. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, May 24th. I thought I would come on in and do a support group meeting. Just getting my computer all set up. And my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you ever again about your IC, right? Because seriously, you haven't done anything wrong. This is not your fault. You are not damaged goods. You are not demanding attention. You do not have a mental illness. You do not have anything like that going on with you. You are hurt. You have a pelvic injury. You have a pelvic injury. And so our job is to give you the information, the education, and the knowledge that you need so that you can be an advocate for yourself, so that you can have really good, powerful discussions with your doctors about what your treatment options are, et cetera, et cetera, et cetera. Now, this is normally I do them first and third Sunday of every month. This time, however, I'm really getting into the groove of doing them every Sunday. I already have our Zoom meeting set up. We did a 4-hour meeting last Sunday. We did 3 hours on Facebook Live, YouTube Live, and then we switched over to Zoom. And I'm telling you, we had a hell of a great time on Zoom. And so I think we're going to switch it over to Zoom sooner rather than later. Hello, Nancy. It's nice to see you. Hello, Yesenia. Nice to see you too. Now, I'm looking at Facebook right now. All right. All right, hold on a sec. Hello, Barbara on YouTube. Nice to see you. Hi, Donna. Nice to see you too. Let's see here. Hold on. So I have decided that my hair is probably going to be down past my butt by the end of the year. Do you see how fast this grows? Look at this. Remember last year at this time, it was all the way up here? Yeah, it's all the way down here. My hair grows so fast, it's ridiculous. So anyway, I hope you all are feeling pretty good today. I'm feeling pretty good overall, gotta say. Not a lot has happened in the IC world today. What we've been doing in my office is we have been finishing up our spring magazine, which should be done tomorrow. So I will have that magazine out for you. You know what? Let me go get it. Hold on a sec. Hold on. All right then. All right. So the biggest news that we had on IC in the last week is we now have 4 federal lawsuits about Elmeron and eye disease, including the first lawsuit asking for there to be a fund set up so any patient taking Elmeron will be able to get their eyes tested on the company. Now, it's the same law firm that has filed all of the lawsuits, and the law firm is, hold on a sec. So I have a really big interview in our magazine with the attorney who's filing the cases. And so I think you're going to find that incredibly interesting and important to get an idea of seeing the tactic that they're taking with these lawsuits. For those of you who don't know, Elmeron, the only oral approved medication for interstitial cystitis, has now been linked to pretty severe retinal disease. And in fact, the first patient that they filed the case on was actually legally blind because of Elmeron. And they're really bringing in 2 critical points in these lawsuits. Point number 1 is the belief that the company withheld information to customers and medical care providers by not telling them about these severe retinal effects. And number two, the other, I think, valid point in all of these lawsuits is the labeling. The labeling. Why hasn't the label been changed? Now, here's something that I just learned that stunned me when I read case number 4, which I read a couple of days ago. Did you know that last September, the Elmeron label in Canada was changed to include the eye disease and to suggest eye examinations? They changed it in Canada 9 months ago. Well, why not the United States? Why haven't patients in the United States been given this same warning? Why hasn't the label been changed here? And so that stunned me. And we also know that when the European Union approved Elmeron last year, they also included something in there to let people know about the eye issues. And yet again, not the United States. Like, why? Why shouldn't IC patients in the United States know that this is an issue? Most importantly, they're bringing up a medication that everybody's talking about right now, hydroxychloroquinolone, also known as Plaquenil. Plaquenil is used by lupus patients and malaria patients, if I remember correctly. Now, I might be wrong. Did I say it right? I might have gotten the name slightly wrong. Anyway, Plaquenil is correct. The scientific name, don't quote me on that. Plaquenil is known for causing retinal damage. It is known for causing increasingly severe retinal damage even after it stops the medication. And so the lawsuits talk about all of the warning notifications for Plaquenil. Patients using Plaquenil to have a baseline eye examination. They include constant monitoring. And they say, well, if it's being done for Plaquenil, why isn't that same thing being done for Elmeron at this point in time? And many of you know that last year, we were asked to present the data from our research study, which showed, now the IC network, we are the support group that broke the story about the Elmeron eye issue. Okay. And I did it with a very, very heavy heart. It was exactly 2 years ago on Labor Day. And that was because I had read a letter to the editor in the Journal of Urology, which referred to an article in the Journal of Ophthalmology. Anyway, long story. I've talked about that before in these support group meetings. Don't need to go about that again. I felt and still feel and will forever fight for your right to know. You should know what the risk versus the benefits of potential treatments are, right? You should know that. It should not be withheld from you. And that ultimately is the kernel of this case, is did the company know that this was happening? We knew in their first, in the big clinical trial that led to the approval of Elmeron, that in that first 4-year study, they noted eye issues. Retinal hemorrhaging was one example of eye issues that were happening. And so I think the key point here is, all right, so in your first study, here you've got eye issues. What did you do to monitor them? Did you monitor them? I mean, that's an important question. Did you monitor them? Who knows? Who knows? So discovery in this case is going to be fascinating. I know that they were having trouble serving them because a lot of businesses have been closed because of COVID. And so, but they are cases of record now filed. I think 1 in Connecticut, 2 in Pennsylvania because the company is based in Pennsylvania. And I think the third one was in another state, or the fourth one was in another state, but I don't remember off the top of my head. So that really is the big news that we have had this week. The other articles that I've gotten here, okay. So What do I always talk about in these support group meetings is you are an anatomical mystery to be solved, right? Not everybody's the same. Not even close to being the same. We are long past those days where we thought IC is an incurable bladder disease. We now know that in many patients, if not most of you, there are other things in the pelvis contributing to your symptoms. We know, for example, that the urethral diaphragm muscles, if those are tight, will give you frequency urgency. And when we look at therapies, it is an undeniable fact that pelvic floor physical therapy helps a tremendous amount of patients, far more than Elmeron ever did. We also know that if you had fibroid tumors, if those fibroid tumors are removed, the urinary symptoms improve dramatically. We know that if there's black mold in your house, black mold can cause urinary frequency urgency. There is this whole list of things that you've got to rule out. And for those of you who seriously, you're not getting better. You've done bladder therapies for years and you're just not getting better. The question is why? Especially think about it. Think about how many of you have a cystoscopy and your bladder is normal. I wonder, does that mean that maybe, just maybe, your condition isn't really coming from your bladder? Yes, it's giving you frequency urgency. I understand that. But guess what? Other things can give you frequency urgency. So Stacy Shannon, a writer for the IC Network, I gave her an assignment a couple months ago to do an article on pelvic congestion syndrome. I don't know if you know what that is. That's basically... See, that's the article that she's written. Pelvic congestion syndrome is the equivalent of having very, very large veins, like varicose veins in your pelvis. And this is, I mean, gosh, she did such a great story on this article, and it taught me so much that I did not know. So I will tell you that pelvic congestion syndrome is the enlargement of veins in the pelvis. The enlarged veins can cut off adequate blood flow to certain parts of the pelvis and or body and cause problems. While some women with varicose veins in the pelvis have no symptoms, the veins cause pain for many, many others. And what was so interesting is the symptom, because I know in the past I've talked to patients who've had this symptom. Well, the main symptom of PCS is pelvic pressure that gets worse with gravity and during the day. So as the day goes on, or the more a woman is on her feet, the worse the pain gets. And there can be other symptoms, including increased urination, painful urination, pain, and sexual intercourse. Let's see, pelvic congestion syndrome patients often have other conditions such as Ehlers-Danlos syndrome, May-Thurner syndrome, or Nutcracker syndrome. I don't know what that is. Nutcracker. Okay. To the men in the room, I apologize if you've just cringed. I don't know what that is. Let's see. They can have IC, chronic fatigue, IBS, TMJ, back pain, fibro. PCS can be the result of pregnancy. Veins in the pelvis enlarge during pregnancy to accommodate the increased blood flow. For some women, especially those who have had multiple pregnancies, the veins stay enlarged and lead to symptoms. However, it's not unique to women. For many years, doctors have been diagnosing varicocele in men, which is varicose veins in the scrotum, because the veins are more visible in men. Without doing any sort of test or procedure, varicocele has been more widely recognized, studied, treated, and covered by insurance. So as we know, with IC, many patients have been told it's all in their head. Many patients have been told that it's not real, that it's psychosomatic, or that a patient is tense, yada, yada, yada. You know the story. Today, you have to see a interventional radiologist. An interventional radiologist is the person who can adequately study the pelvis correctly, look at the veins correctly, and then they use something called an intravascular ultrasound. to determine whether there is a vein issue. It's a mini ultrasound probe. And they say very clearly you should not just go to any radiologist. It has to be a true interventional radiologist. Anyway, this article is kick ass. It is so, so good. But here's the thing. Women have suffered for years with this terrible pain from these varicose veins. And guess what? It's completely treatable. It's treatable. And what they do is they just work on the veins. They will put a stent in narrow veins, and then they will bring down the veins that are swollen, just like they do with varicose veins in your legs, right? So again, when you've got pelvic pain, when you've got interstitial cystitis, you should not assume that it's always from your bladder. It doesn't necessarily mean that it's from your bladder. It can be from structures just outside of your bladder. That's the thing about the pelvis here, guys. The pelvis is the anchor of the human body. There's a lot of work happening in a small confined space. You've got the biggest bones in the human body, the hip bones. The bigger the bones, the more weight it's meant to carry. So what that means then is that the pelvis carries the weight of your torso. The pelvis also absorbs the stress when you walk. If you walk and stumble, that weight, the forces of that weight get pushed right up into the pelvis. If you've got one leg longer than the other, so your hips are like this, your hips are uneven, right? And so you're walking uneven. That could be triggering chronic pelvic tension that could then be triggering IC and bladder wall breakdown through what we call a somatovisceral reflex. And we can explain that later. So anyway, at our next meeting, we're going to go ahead and do our launch, our formal reveal for our spring magazine. I'm excited to have that done because I've got to get started on the summer magazine. Okay, now the other thing for this meeting today, what we're going to do is we're going to do like 90 minutes traditionally through Facebook and YouTube, and then we're going to go on over to Zoom. I already have the Zoom meeting set up, and anybody who wants to Zoom, we're going to go ahead and do a Zoom meeting because we had a blast last week. At least I had a blast last week. Okay, so normally the way I do these meetings is I start with 30 minutes of a little lecture, which I've already done. Then I'll just take your questions. And let me just introduce myself. My name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I am the longest serving IC support group leader in the United States at 27 years and counting. I started my first support group actually in 1993 from my bed because I could barely walk because of my IC. I had a doctor say to me, Jill, you will forever be a burden on your family. You will live in pain your whole life. Get used to it. And that was a moment I needed. That was in the summer of 1993. That was like literally, it would have been literally in 6 weeks from now, 27 years ago. And I needed that. You know what? I'm going to tell you right now, I needed that because up to that point, I was in a very suffering passive mode. But when I had a doctor say to me, you will forever be a burden on your family, I went, what? I have 3 college degrees, dude. I still have my mind. I still have my brain. I still have my hands. I still have my arms. I will prove you wrong. How dare you say that to me? And you know what? Started my first support group from my bed a couple weeks later. And he's wrong. I've been pain-free for years. Every now and then I have a little tiny flare, but nothing like it was. He was freaking wrong. And so for those of you out there who absolutely believe that you're going to be in pain for the rest of your life, listen, I am here. I am living proof that that's not necessarily true. It begins with understanding your unique presentation of IC. Your unique presentation of IC, because we cannot make broad strokes. Everybody is unique. Everybody is different. I was working with a very lovely man this week who, let's see, God, I talk to so many patients all the time. I believe that he'd had IC for about 13 years, started when he was 19 years old. Extreme symptoms at this point in time. a lot of frequency, a lot of urgency, struggling to work, and with a family that wasn't as supportive as it could have been. He was really struggling with family members who just were not supporting him, didn't think it was real. You know, the little jabs, the little, yeah, come on. When you going to get a real job, Jill? When you going to get better? Oh, come on, really? It's your bowel this time? It's your bladder the next time? You know what I mean. You know those little smarmy, deeply hurtful comments that people make to us who don't understand that we have a real thing. And so he was really struggling with that. And anyway, we had a fantastic conversation. Man, listen, I'm your girl. If you need a pep talk, if you need ideas on how to work with family, that's me. You are absolutely welcome to call my support group. We have a 800 support group number. You're welcome to call. But see, the thing that was just so interesting is that, especially with men, is getting you to walk back in time. Let's just kind of go back. Let's go back 13 years ago. So what was happening 13 years ago? Did you fall? Did you have a car accident? Can you remember any pelvic traumas at all? Were you riding a motorcycle? Were you riding a bike? And the answer is yes, I rode bikes a lot. Okay. So we know that riding a bike has the potential of traumatizing your muscles and traumatizing your pelvis floor. And it's like, okay, do you remember anything else? Here, you're 19 years old. You just graduated from high school. Anything else? Do you remember any traumas? And he goes, yeah, I do, actually. I was working in a job where I was moving heavy things down from a shelf, and they kept hitting me in the pelvis, like really hard thumps right in my pelvis. And as we, continued to develop this story and kind of go through history, he had what we see in a lot of people, and that is a history of pelvic traumas. Sometimes they're little traumas, just little traumas over time that build up and build up and build up. And then for some of you have big traumas, like another man that I was working with who was run over by a truck and had his pelvis crushed, or a woman who was hit by a car. So there can be little traumas, or there can be one big giant trauma. But eventually, at the end, if that muscle trauma is not addressed correctly, it will cause a wide variety of issues to happen. Most specifically, blood flow gets reduced. And when blood flow gets reduced, it's impossible for the bladder to be healthy, just like it's impossible for other structures to be healthy. I was reading another journal article, and it was interesting because it measured blood flow to the bladder when muscles are. It was when blood flow was compromised, and I'm trying to remember what compromised the blood flow. It was either muscle or it could have been something else, but I think it was muscle. Anyway, in this study, the bladder wall was only getting, on a scale of 1 to 25, 9 out of 25 in terms of blood flow, whereas a healthy bladder would be getting 25. So those bladders in that study weren't even getting 50% of their normal blood flow. So how can a bladder be healthy if it is deprived of oxygen and nutrition and all that other stuff, right? How can the bladder wall be healthy? It can't. It cannot be healthy. And so our therapeutic priority now for many, many patients is not to calm and soothe the bladder, because the bladder isn't really the problem. Ooh, I'm sweating. Woo! Our therapeutic priority is to restore blood flow. When we restore blood flow, the bladder gets the oxygen and the nutrition it needs to be healthy again. You know what? It's going to be 103 here, 105 here all week. So it's going to be 100 today. And where did I put it? It's probably 90. It's probably 90 in my office right now, and I can't turn my air conditioner on because I have to clean it. Okay, hold on. Where did I put it? Oh, not that you need to see my that. Okay, hold on. Where's my little fan? Oh, here it is. Yeah. Oh, wait. Actually, let me get a thing for you. Okay. Woo. I got my little fan. Oh, there you go. How do you like that? It's my little Disney fan. Yeah. I remember here, I live in Northern California, Sonoma County. Our hottest day of the year is usually in the first 10 days of June, and it has hit 118 here. Just crazy. And I'm afraid that this year is going to be the exact same thing. Oh, okay. Okay. So again, sorry. Think about this young man. From the age of 19 on, he is struggling. He is struggling to work. He is struggling to have a normal relationship. He is not getting the support that he needs from family members and friends. And guys, I'm telling you right now, listen, it's not a sex issue as much as a knowledge issue and compassion issue. It doesn't matter if you're a man or a woman. Many of you have absolutely wonderful partners who will be there for you through thick and thin. And some of you have partners who are immature and who are not compassionate and just don't freaking have a clue. And sometimes, again, as I made the offer in his case, I would be happy to talk with both of you at the same time to see if I could give some context there. All righty then. So let us hold on a second. I also was talking yesterday with a woman from another country. I won't say where because I'm hoping that she's in here. Where the therapy that she was being given and had been given for years is chlorpactin. Now, chlorpactin has not been used as a therapy for interstitial cystitis in the United States for 20 plus years. Chlorpactin is a bladder wall stripper, just like silver nitrate is. This goes back to the day when they thought that if you stripped off the bladder wall, a new healthy bladder wall would grow. Now, we don't do those anymore. Kristen says, hello, I've been having terrible hip or groin pain lately at night. Keeps me up. All right. Okay, so hold on a sec. Let us... So I'm simulcasting Facebook, YouTube. Facebook here, you guys, just so you know, I am 18 minutes behind with your questions. And it's not going to let me scroll back. Rhonda says, a military doctor told her not to use Elmeron. Awesome. Melody says, should I get off Elmeron? Melody, you need to come on over to our website, icnetwork.org, and read the article and read the studies. And the short answer is, at least get your eyes tested first. And if you're showing any signs of retinal damage, you get off of Elmeron. That's what everybody says. That's what every researcher says in the eye, in terms of ophthalmologists and urologists. That is a given. Emily says, finally have another appointment with a new urologist next month. Awesome. Emily says, how do I ask about finding out what subtype you are? Well, so Emily, it's something you can really figure out on your own. You got to understand that what you're hearing from me is stuff that your local doctor probably is not going to know. You have to remember that very few people have a job 50 hours a week or more working with IC. And that is my job. I read every research journal that I can. I sat on the U.S. Army IC research panel. I have on our medical board the top IC doctors in the world. And so I'm talking about things that national doctors and international doctors are doing, not necessarily local doctors. Okay. So let's talk about subtyping for a moment. Let me get my... Is this the right one? Nope. That is not the right one. Hold on. Now, if we were over on Zoom, I could actually just go ahead and do my online thing, but unfortunately I can't do that. Right, yeah, we will be doing Zoom in a little bit. Here we go. Now, I know some of you have already gone through this over and over, but let's just be real here. Even if you think you know your subtype, you still could miss something. There are lots of different things that potentially are going on. And so let's just go through this really quickly. So it was the European IC researchers 15 years ago who basically split off from the American researchers and created their own society called the European Society for the Study of IC. They did not like the direction that the American research community was doing. They were correct in that assumption. And they felt that there were variations of IC. So one of the very first things they did was they created a graph or a schematic that identified 16 potential variations of IC, from a patient with 0 symptoms to a patient with the absolute worst symptoms. Their subtyping system is based on pathology results. Not only do they look at the bladder and they look at the condition of the bladder, they want everybody to have a biopsy, and they base their diagnosis really on what the biopsy shows too. So the challenge with that system is that at least here in the United States, and really in most of the world, the healthcare system is not going to pay for that degree of testing, nor do we have the pathologists who are trained in that type of testing. And so they're kind of doing their thing over in Europe and leading the way in many, many respects. They're the ones who have done some really pivotal research that we are all paying attention to. Canada uses a system called UPoint, and the UPoint system asks doctors to look at your symptoms, to look at your bladder wall, to test for infection, to test muscles, to look for other neurologically driven syndromes, and to look for anxiety and catastrophizing, because that also can play a role in an exacerbation of pain. So the UPoint system, we were really excited to see when it came out about 10 years ago, because it at least told doctors to look at the whole body. Just don't look at the bladder, look at the bowel, for God's sake. So many of us have IBS, like what the hell? Look at the bowel too. In the United States, we are amazingly kind of the slowest in the world when it comes to adopting some of these new variations. So our American Urology Association has only gone so far as to say that we recognize 2 variations, Hunner's lesions and non-Hunner's lesions. But Dr. Christopher Payne, who ran the IC research program at Stanford University, took his shot. And a lot of researchers around the world now, everybody's talking about phenotyping and subtyping. Everybody is trying to understand the unique variations of IC so that we can give you the right therapy. And so Dr. Christopher Payne, about 5 years ago, put out his proposal. And he did it in a really provocative way, because he said, hey, we should be treating IC patients like cancer patients. Now, I read that and went, oh my God, why would you say cancer and scare people? But when you actually read the article, he says, no. Listen, when somebody's diagnosed with cancer, they don't just say you have cancer and walk away. They say you have cancer of the left breast that is estrogen dependent type 1, 2, 3, right? And a diagnosis of cancer is so specific. You know what? I got 3 different screens on my computer showing my face talking to me, and it's driving me crazy. Hold on a sec. All right. Ooh, that's better. Okay. So, what was I saying? Okay. So 3 years ago yesterday, I had a hysterectomy. My diagnosis was complex endometrial hyperplasia with atypia and a vague architectural complex. What does that mean? Early uterine cancer. The diagnosis was so specific that we knew exactly what to do. Which was a hysterectomy, which is why I had a hysterectomy. I flash back 3 years ago at this moment, and I get chills thinking about how I felt the following day. It was pretty brutal. He argues that a diagnosis of interstitial cystitis is fairly meaningless, that you don't really know what to do next, and neither does your doctor. And if your doctor's treating IC out of a textbook, they give you Elmeron, they give you DMSO, they give you the diet, and you move on. And he said there's no logical, intuitive pathway. When a patient is diagnosed with interstitial cystitis, you walk out of the clinic and go, what the hell does that mean? What do I do next? And for many urologists out there, they don't know what to do next either. So, how do we give you an intuitive treatment pathway with a more specific diagnosis? The more information you have, the better you are able to select treatments and choices that will meet your unique needs, right? So, this is his system. So, Chris Payne is now at vistaurology.com. He's in San Jose, California. He's in practice with his wife, Jeanette Potts, who also is a pelvic pain specialist. So they are really the pelvic pain center on the West Coast at this point in time. Subtype number 1, Hunner's lesions, right? So we know this is a different, distinct group of patients. If you have Hunner's lesions, you're different from everybody else. Because when we biopsy a lesion, it is filled with massive inflammation. There is war happening in that Hunner's lesion bladder because inflammation is a sign that your body is fighting something. So here, these are pictures of Hunner's lesions. So you notice it has a center red area, and then it has red arms that stretch out from it. It's called a stellate appearance. These are Hunner's lesions. What the hell causes a Hunner's lesion? Isn't that the question? What causes a Hunner's lesion? Well, we have two theories. Theory number 1 is that it is a nerve that is massively inflamed. Nerves that become inflamed release substances called substance P, which damages tissue. So if you've got a nerve that is massively, massively inflamed, that nerve can cause tissue damage. But the other thing, which came from Europe, is we now have some research that shows that patients with Hunner's lesions may have viral infections. So, y'all think when you got a bladder infection, you're thinking bacteria. Well, guess what? Viruses can live in the bladder too. And so can fungus. And so we now know that the Epstein-Barr virus, that the polyoma BK virus, that the HPV virus, and even herpes can be found in the bladder. So now we know why Elmeron doesn't work for Hunner's lesion patients. I mean, if it's a nerve that's massively inflamed, we got to do things to calm nerve down. We don't need to protect the bladder. We need to calm the nerve down. If it's a virus, then we need to be working on that viral infection to some degree. So that's IC subtype 1. And understand too that there still may be more emerging research which will help us understand more why lesions occur. But you just have to understand that lesions, non-lesions, absolutely different groups, and there is an absolute move that everybody agrees around the world, all the researchers, all the top IC tier people, that Hunner's lesion patients are distinct and should be in their own category, in their own disease. Okay, IC subtype 2, hold on, bladder wall driven. Because hello, my friends, the bladder, like any other part of the body, can be hurt. So we know your bladder wall is driving your symptoms if you have pain as your bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. Ow, ow, ow. Where's the bathroom? Oh my God, ow, it hurts. As soon as you pee, oh, you feel better, right? So let's look at a typical bladder wall patient. Okay, look at the difference. Hunner's lesion, big bloody mess. This is different. These are little red dots. We call these petechial hemorrhages or glomerations. This is more traumatic injury, potentially. This is really kind of what we look for with, in my opinion, this is more of a traumatic injury type of patient. So how does the bladder get hurt? Chemical exposure. If you've gone through chemotherapy, anybody who's gone through chemo, especially the old style chemo, It hurts. The chemicals injure the bladder wall. If you went to raves, if you partied a lot, you did ecstasy that was cut with ketamine, or you use ketamine, guess what? It's like an industrial solvent to the urinary tract. I mean, from the kidneys down, ketamine is devastating to the urinary tract. And think about it this way: as your bladder fills with urine, you get fuller and fuller and fuller and fuller and fuller. Urine is getting into these holes, getting into these wounds, and it hurts bad. Bladder pain is characterized by being relentless and difficult to ignore. It's agonizing. It's absolutely agonizing. And that's why so many of us, you just can't sleep. I don't think I slept a full night for a year until I actually got the right treatment. So when urine goes into these wounds, it hurts. And God forbid you have been drinking Mountain Dew or iced tea or water with lemon or coffee or green tea or cranberry juice or pasta. Hello, acid on a wound hurts. So in this subtype of bladder wall driven, we have some subtypes, right? So subtype number 1, chemical injury. And again, chemo, absolute. Or if you were just completely addicted to Diet Coke or Mountain Dew, listen, over time, your bladder was not designed for acid all day, every day. You got to remember, your bladder was designed thousands of years ago when the only acid in the environment was when fruit was ripening. And so the chemical toll of life in 2020 is devastating to that bladder. And eventually that constant acid load is going to start breaking things down, including your bladder wall. So chemical injury. Second thing we're going to look at is estrogen atrophy. Because your bladder, this is the thing that's so cool. Hold on, I want to grab this real quick. Now you got to understand, I was in college. I never thought I would be spending time talking about the bladder, something that, most people don't usually want to talk about. I think the bladder is a really interesting organ. Oh, it's so hot here. Holy moly. The bladder is a really, really interesting organ because it's the only organ in the human body designed to hold toxic waste. Because urine is body waste. Urine contains ammonia, urea, all sorts of stuff like that. So think about it. How can a bladder hold ammonia for hours at a time and not get damaged? That's fascinating. That's fascinating. The bladder is basically a toxic waste retainer, right? Or container. So how can it do that? And the answer is that your bladder is like your mouth. It is a hollow organ covered with mucus. There is a nice thick mucosal barrier in your bladder that protects the cells of your bladder from the irritants in your urine. And here it is. Now, granted, it's not blue. It's like your mouth. It's pink, right? But this is an educational resource. So your bladder has a nice thick coating of mucus directly over the urothelial cells, which is directly over the blood vessels and nerves. And so what happens when you lose mucus? Bam, bam. Irritants in your urine get where it's not supposed to be. Unfortunately, this mucosal barrier is estrogen dependent. So when you're young, you got lots of estrogen, you can go to town drinking Diet Coke because you got a nice thick coating of mucus. But guess what? As your estrogen levels start to drop, your bladder wall gets thinner, your bladder mucosal barrier, your gag layer gets thinner and thinner and thinner and thinner. So what does that mean? Number one, that's not a disease, that's aging. We don't treat that like a disease. That's aging. Every woman goes through it. I have been going through it. If you had a hysterectomy in your 20s, you are going through it. If your hormones have never been normal, through it, right? And so estrogen atrophy is going to potentially influence the bladder wall. So I always tell everybody, you got to pay attention to the quality and health of your skin. If your vulva is dry and your vagina is dry, so is your urethra and so is your bladder. And so we always want to be on top of that. And then the third thing we want to think about in this subtype of bladder wall driven is chronic infection. Because yes, you could have a chronic infection. You might have a chronic bacterial infection, Or more likely, you might have a chronic fungal infection. We had yet another research study that came out in the last month, yet again, did not find bacteria, unusual bacteria, but we are continuing to find overgrowth of fungus in the urine of patients with IC, especially patients who are flaring and in severe pain. Now, we knew 5 years ago from the MAP Research Network that many patients who were flaring had an overgrowth of candida in their urine. And unfortunately, a typical urine test doesn't test for candida. You got all the symptoms of infection: frequency, urgency, pressure, pain. You are crying on the phone with your doctor. Please help me. I think I have an infection. You go leave a urine sample. It comes back negative. The doctor goes, you don't have infection. He doesn't explain it right. Yeah, you don't have a bacterial infection, but could you have a fungal infection? Now, this is very new. This is very, very new. The flaw with typical urine testing is it doesn't test for fungus. And I'm going to argue that if there's ever a group of patients who are completely overexposed to antibiotics, which can create the foundation for fungus to grow, it is the lower urinary tract IC patient. Every single one of us here, every single one of us watching this meeting or in this meeting right now have all taken antibiotics at one point in time for these symptoms. And when you take an antibiotic, you kill the bacteria that keep fungus in check. You kill the bacteria that keep candida in check. And we had a research study this spring which showed that in one study, they identified up to 13 different fungal species in the urine of patients who had bladder pain. And the more fungus you had, the worse pain you had. So this, I'm going to predict in the next year or two, is really going to blow up. It's going to blow up. And this is also why you as a patient have to start getting a little bit more involved. You can't be passive here. You cannot be passive here. You've got to understand, well, number one, all the urology conferences are canceled for the year. That's a given. But, you know, your doctor doesn't have time to read all this, especially now that they're treating COVID. You know, we've got urologists treating COVID patients now. Urology clinics have been emptied because they need these doctors in the emergency room, especially now in some of the states in the Midwest and in central USA. So you have to be a lot more proactive now. One of the ways that you can be more proactive is you can request next generation urine testing. This is what they're all doing in all the IC research studies now. This is what all the infectious disease specialists are doing. They're not using urine cultures anymore. They're not specific enough. When you do a next generation urine test, they look for DNA and they identify the DNA of everything in your bladder, everything in your urine. They will get good bacteria, they will get bad bacteria, and they will get fungus. The most important part of this is it will also identify resistance genes. You know, they compare the data that they get from this test to these giant databases at the Center for Disease Control because they're always tracking, at least don't get me started. Do not get me started about the state of the Center for Disease Control right now. But what they normally do is they track diseases in depth. And they have giant databases of DNA and antibiotic resistant infections and antifungal resistant infections. And so the advantage of this type of test is it will compare what they find with these big giant databases, and they will be able to identify anything weird going on. You know, I'm very big. For those of you who have talked to me before, you know, I always say I don't like guessing. I like facts. You know, guessing will only get you so far. And if you have been guessing for 5 years now doing therapies and they're not working, maybe it's time to get a few facts. This will at least rule in or rule out any weird infection going on. And this is valid and useful. And the other thing is it's cheap. Now, 10 years ago, this cost $5,000 or $10,000 to do. Now it's under $200. So you can go over to bladderhealth.org, and watch a whole bunch of videos. I built that website 2 years ago, of doctors, urologists who use this to look for weird infections. And I recommend this for everyone. I've done it twice now. I think, again, I like facts. I don't want guessing. If I'm in pain, I don't want somebody guessing why I'm in pain. I want you to look at it. Look at it. For God's sake, look at it and tell me what's wrong there. All right, let's go to the next subtype. The next subtype is pelvic floor driven. So these are the patients whose symptoms began after a muscle trauma, a car accident, a fall, a history of athletics, having a baby, being torn. I was working with a woman this week who, I kid you not, had a third degree tear from her vagina through her rectal wall. That's a major pelvic floor injury. And in this case, what happens is these people suffered a muscle injury that caused muscles to get tight, started restricting blood flow, and then the bladder eventually got affected through what we call a viscerosomatic reflex. The bladder wall will start to break down if it is deprived of oxygen and nutrition and stuff like that. Our therapeutic priority for these patients, and for many of you, your cystoscopy is normal. Your hydrodistension is fairly normal as long as it wasn't injured during the procedure itself. And you've been on bladder therapies for years and they don't work. You're never quite better. You're never quite better. Why? The reason why you're not better is because they haven't dealt with the fundamental problem. And the fundamental problem is blood flow. It's blood flow. We got to get the blood flowing through the pelvis again correctly. And so the therapeutic priority for this one is to get these muscles healthy again, to restore blood flow again, so that the bladder can get the nutrition it needs to be healthy again. And that also applies to the vulva, because many women with vulvodynia, it's also being driven by tight pelvic floor muscles, or men with scrotal pain or rectal pain, or pain with intimacy, or pain at the tip of the penis. That can all be referred from tight pelvic floor muscles. So this is, in my opinion, the biggest subtype. I think that far more of you have pelvic injuries than you realize. The next subtype is pudendal neuralgia. These are the patients who have a nerve injury. So these are the patients whose symptoms are very positional. You're fine when you stand, but when you sit down, it hurts. Or when you bend over, it hurts. You might feel a buzzing sensation. You might feel a persistent arousal sensation called PGAD. And for these patients, a diagnosis is made not only by studying the muscles, but they might even do nerve blocks. So again, I think it was with the guy that I was working with, I was talking about earlier, that they actually did a nerve block and it actually turned his pain off. And yet he didn't quite connect the dots. It's like, wait a second, the nerve block turned your pain off? Yeah. Then why are we doing bladder therapies? Wait a second, did you ever ask where the nerve is compromised? And, kind of getting them back into that line of thinking is critical here. And the last subtype is central sensitization. So this is my subtype. This is also known as functional somatic syndrome. That's kind of another way of looking at it. So my interpretation of this is that there are two variations of central sensitization. Number one, inheritance. Because every woman in my family on my mother's side, going back generations, has a sensitive bladder and a sensitive vulva and a sensitive stomach and sensitive skin and drug sensitivity and food sensitivity, all that sort of stuff. So remember, we are indeed the product of our ancestry. And we see more sensitization in people who are redheaded and of a Northern European descent, right? So if you've got family from Ireland, Germany, Norway, Sweden, England, anything Northern Europe, we tend to see that a little bit more. And I remember that from, I'm going to say, a study like in the 1990s. A study in the late 1990s absolutely found this sensitivity But the other time the central sensitization can happen is after an injury of some type. If you've been injured, you can be hurt. Those nerves get hurt, and an injured nerve becomes a sensitive nerve. That means that it's easier to turn on, and it takes less stimulation to turn that nerve on. So if you looked at my bladder is completely healthy. But if you put even just 100 cc's of fluid in my bladder, guess what? I need to pee because my nerves are more sensitive. They're easier to turn on. You put somebody without central sensitization who's got a completely normal bladder, you can put 1,000 cc's of urine in their bladder and they can walk around for hours. You put 100 cc's of fluid in my bladder and I'm feeling it. I might be able to walk around for a little bit, but I'm definitely feeling it. So that's central sensitization. And again, that's not a disease. Our therapeutic priority here is to calm and soothe our nerves. And the odds are, for those of you who grew up sensitive, like I did, you're already doing it. You're already doing it. You're not using chemicals in your home. You're not using Febreze. You're not using bubble baths. You're not using caustic chemicals in your home like oven cleaner because, you're really wickedly sensitive. That's who we are. So those are the key subtypes. So my subtype is IC subtype 5, IC subtype 3, because my bladder wall's healthy. My bladder wall's absolutely healthy. 3 years ago, yesterday, we proved it. I had a hydrodistension. Looks perfectly normal. But yet there's absolutely no doubt that I'm an IC patient because number one, my nerves are wicked sensitive in my bladder. And number two, I happen to have a pelvic floor injury on my left side. So my therapeutic priority is to calm my nerves and work on my muscles. Now, some of you might be different. The ketamine patient, you've got a bladder injury. You're going to be working on your bladder. So there you go. Oh, it's hot. Oh my God, it's hot. Woo. Hold on. Let me drink some water here. Hey, I'm going to go get some ice water. I'll be right back. I should have cleaned my air conditioner yesterday. All right, hold on. All righty. And this also explains why, oops, hold on. Some of us can drink things that others of you can't drink. I can drink Gatorade. I don't drink it a lot. I can drink Gatorade. Why? Because my bladder wall is healthy. And they gave me a picture of it, but I lost it. I don't know where it is. But for those of you with Hunter's lesions, yeah, you're not going to be able to drink Gatorade. You're not going to be able to drink a lot of stuff. That's why there's such a variation in diet. All right. Whew, man, was I talking there for a while? Let's just take a step back and go through some of your questions here. So down here, if I'm looking up here, I'm looking at Facebook. If I'm looking down here, I'm looking at YouTube. So let me check here. Hi, Michelle. Hi, Lewayne. Dwayne says, I have a question. If you were the only able to purchase one bottle of any of the vitamins on the website, what would it be? We only sell one vitamin on our website, which is the Bladder Smart Low Acid Vitamin. If you're talking about the supplements, because they're not vitamins, they're known as over-the-counter nutraceuticals. If I could only do one, well, for my subtype, and my age, it would be Bladder Builder because it has a bladder wall coating effect from the chondroitin combined with the PEA, palmitoethanolamide, to reduce pain and to calm nerves down. And so for that type of patient, it would probably be Bladder Builder. I personally just take PEA myself. Let's get these down. I'm going to try not to flash you. Oh my God. Like, seriously, tell me I'm wearing a dress so I don't flash you guys. Okay. All righty then. So in terms of the vitamin, the low acid vitamin is called Bladder Smart. We don't carry Multi-Right anymore. Multi-Right's pill was too big, and they were having a little manufacturing issue with it. It was getting a little bit harder to swallow. We like the idea of doing a capsule instead. And so the Bladder Smart is just a little capsule. And I take this every night myself too. Now, and I can't take a regular vitamin, like a one a day. Definitely hurts. But these are fine. All right. And then we've got the Bladder Builder, which is the most comprehensive supplement that's out there right now. It has the most methods of action. Bladder Rest, which is a simpler formula for people who tend to be a little bit more sensitive. If you're somebody who flares from taking a probiotic, then Bladder Builder is not for you. It'd be better to do Bladder Rest or Cystoprotec, which has been around. This was created by famous ICU researcher Dr. Theoharis Theoharides 20 years ago. He's a pharmacologist, a doctor, researcher at Tufts University, federally funded ICU researcher. Cysto Renew, which has a bladder coating effect with the soothing effect of the aloe, along with, of course, Desert Harvest Aloe. Those are your primary options. And then for those of you who just struggle with pain, or you're looking for something to use on top of whatever therapy you're choosing, Peora is just the palmitoethanolamide formula that was very similar to the IC research study that was released last year that found that PEA was remarkably successful at reducing pain and discomfort in IC patients. And so if you're struggling with a little bit more pain, in addition, and you want to use something in addition to whatever else you're doing, PEA would be reasonable to try. In that research study, there were no reported side effects. I went through as many studies as I could find. I found very few side effects with PEA. It seems to be very, very well tolerated. And so the PEA is viable. It's a viable option. Now, there's no way to say that any supplement's going to work specifically for you. It really is just trial and error. And remember, on our website, we got this whole list of confusable conditions. If you got fibroid tumors, supplements are not going to work. If you've got a Tarlov cyst, supplements are not going to work. If you got black mold in your home, a supplement might help a tiny bit, but it's not going to solve the problem. You are an anatomical mystery to be solved, and we've got rule out a lot of stuff that could be contributing to your symptoms, right? Dave and Gail say, watching live for the first time. Hey, always nice to welcome new people, new watchers. Have had IC for 20 years. Past 5 months has gone to a whole new level of pain like never before. All right, so Gail, just know that when patients get worse, We really look at kind of two fundamental things. The concept, number one, of aging and the fact that, let's say you got pretty steady in your 30s. Let's say your symptoms started in your 30s, but you got things calmed down in your 40s, and then even in your early 50s, and then all of a sudden things started to go downhill. And that could just be estrogen atrophy. And so, again, if your vulva is dry and your vagina is dry, it may be that your bladder and your urethra are now being affected by lower estrogen levels, and you might benefit from using an estrogen cream or something like that. The next time you go to the doctor, have somebody look at your skin down there and let's see if you're showing dryness. But the other thing we want to look at is injury, hun. You say 5 months has been a whole new level of pain. What happened 5 months ago? Did you fall? Car accident? Period of stress? Anything at all like that? I work with I use two mouses, and it gets tricky sometimes. Loane says, "It's nice to see you again. Hope all is well. My question is, if you were only able to..." Oh yeah, okay, we answered that question. Loane says, "I also have pelvic congestion syndrome." There you go. Hi, Sherry. Nice to see you, hun. All right, let's go back to Facebook. All right, now you guys on Facebook, please know that it does not allow me to scroll back. Do not take it personally if I have answered your question. I have no control over that. So just keep asking the question. Heidi says, Dr. Peters wants me to consider cyclosporin. Heidi, that's a good option. It's a step 5 treatment option, and it has been a bit of a miracle drug for people who struggle with massive inflammation. So cyclosporin is a viable option. The challenge is that cyclosporin will be immunocompromised. It will make you potentially immune suppressed, if not immunocompromised, which means you would be more vulnerable to bacterial infections and viral infections. So I would ask him if this is the right time, because it could make you more vulnerable to COVID. So I don't know about that right now. Having IC does not make you more at risk for the COVID viral infection, but cyclosporin, which is an immune suppressant, if you were taking that for IC, you will be at more risk. Okay, Laura says, "Hi, Jill. I'm new to the support group. I don't know the results of my. Okay, I don't know based on the results of my biopsy. Bladder mucosa covered by urothelium with reactive changes on a stroma with slight plasmacytic inflammatory infiltrate with mild hemorrhage and vascular congestion. Clinical diagnosis, ICBPS." So basically what they're saying is that when they did a biopsy, what they found was that this layer was compromised. So you had an infiltrate, which means that something up here was getting down here that was triggering inflammation. And then you had a mild hemorrhage, and the mild hemorrhage is from the blood vessels that may have been injured or damaged by that. And vascular congestion, I don't know about the vascular congestion. That's interesting. It might just be part of it. You guys remember, I'm not a pathologist, so I'm doing the best I can with what I have. And you're always going to verify anything that I say with your doctor, right? Because I'm not supposed to give you medical advice. That's not my job. My job is to educate you and give you options so that you can learn more about it and talk with your doctor about it. So, okay, so what does that mean, Laura, in terms of subtype? That puts you in IC subtype 2, bladder wall-driven bladder injury. What they don't say is if you had a Hunner's lesion. Unless that was that a biopsy taken from the center of a lesion? Maybe. Gabriella, Julie, let's see. Gabriella says, "I'd been in no pain, just a few flares, but during this pandemic time, I began with freaking horrible flares. And not only is my bladder suffering, but sometimes my bowel. I don't want to be under prescription because I get crazy. What can I do? Is everything the stress that we are dealing with?" The answer is probably, I'm going to say there are two two or three things going on. Number one, the stress is real. And when you're under stress, what happens? You subconsciously tighten muscles. And there's just a whole stress response where your body is really physically weakened from the stress. So yeah, I would expect that a lot more patients would be flaring right now, if not from pelvic tension or neuroinflammation. That would be number one. Number two, you're completely disrupted. Like, I don't know about you, but seriously, I am not sleeping normally at all. At all. I have been going to bed. Last night, I got to sleep at maybe 3 in the morning. No matter what I try, I cannot fall asleep. And that is all post-COVID. And it's just worry. In fact, I was talking with my dad last night because he's going to bed later too. He's 97. And we were just talking about the heat coming in, and we started talking about fires and things we needed to do. And seriously, it's stressful. And then you go out and there are idiots out there getting close to you, not wearing masks, not understanding that the purpose of a mask is to protect you from them. And for anybody that I might have offended with that, I don't care. I am trying to protect my parents who are vulnerable. When I go out, I don't want you coughing in my face or sneezing in my face. This is not a first rights issue. This is a responsibility issue. This is about understanding consequences. If somebody walked into a crowd with a bomb and set it off, everybody would be outraged. If you walk into a crowd coughing with COVID, you're going to kill as many people. And so this is serious here. There was 91 people affected by one hairdresser, and now another 60 affected by another hairdresser who was seeing people sick. Okay, don't get me started. Diane says, looking for an MD that does a cystoscopy with a hydrodistension. We have a database on our website. Just go over to icnetwork.org. Brittany says, have you ever heard of stress and anxiety alone bringing about IC? Sure. I was under consistent stress with a move and a new, very stressful job before my symptoms started. My symptoms seemed to be primarily bladder wall driven, but I just don't understand how this could happen. Well, number one, you're tightening muscles. You're restricting blood flow to your bladder. It's very common. I mean, mine started when I started having bladder pain. I was in a job I absolutely hated. My stress level every day was terrible. Ileana, hey. Oh, you guys, hey, we've got somebody famous in the room. Ileana Brockman. Ileana Brockman is one of the old-time IC support group leaders like me, and she started a wonderful company. She is an example of somebody who is absolutely not going to sit down and not do anything. She really started something new. She created Easy Med or IC Relief, and it's and hold on, before I get to this, somebody said, is vaccine now? No, there's no COVID vaccine, none at all. Your best defense is to stay at home and stay away from crowds, especially if you're in states where the virus is increasing. Listen, this is not a political issue. This is a safety issue. I told the story, you guys, last week about this, that, I have a pharmacology degree. So I've got a chemistry degree, then I have a drug development pharmacology degree, and then I have a psychology degree. So the first major class I took for my pharmacology degree was a public health class. And the dominant topic was HIV/AIDS and how desperately concerned they were that it would mutate and become airborne. And I never, ever, ever forgot that class, because I sat there in that class just stunned. When you actually take a public health class and you understand the ramifications of viral infections, what they can do. This is not a political issue. It's a safety issue. Okay, so let's talk about Ileana Brockman here. One of my favorite people, even though we've never, Ileana, I don't even know if we've met. Did we meet at a conference? Did we meet at a conference? As I use as my aid, as my pointer, this wonderful glass wand. She created a company that creates wands for people with pelvic floor dysfunction, because your pelvic floor muscles are fairly deep in your pelvis, and your finger is not going to reach it. If you've got a trigger point up by your cervix, or if you got a trigger point over on the left side or the right side, and it's tight and burning, you can do something about it. And normally, physical therapists will suggest that you get a wand of this. They can be straight or curved, and they will teach you how to use this so that you can get your muscles back under control. Yes, it is a little bit weird at first, but I'm telling you, my friends, it works, and it works beautifully. Who knew that you could have muscles deep in your pelvis that could be masked? All right. Wait, somebody just said, was messaging just disabled for our page on Facebook? What? I did not do that. I did not do that. You guys, we're going to be switching over to our Zoom meeting very, very quickly. Ileana is recommending pelvicguru.com as a place to look for pelvic floor physical therapists. Cheryl says, I have 5 out of 6 subtypes. As far as sleep, I do not sleep. I'm up 10 to 20 times a night, or every 10 to 20 minutes. Some nights are every hour. Cheryl, we got to talk, girl. Squad says, is there any good news with COVID? The answer is anywhere but the United States or Brazil right now, or Mexico is starting to have a pretty bad problem. Let's see. Dale, dude. So here, Dale was in our meeting last week, and he had just come down with COVID. Dale is an IC patient, and Dale, you're still sick, but you're not in the hospital. That's a good thing. I hope you're feeling better. You did learn how to make Pedialyte from scratch with no potassium. Dude, seriously, could you write that down so I can put that out? Lupita says, what do I think of pumpkin seed oil capsules? I can tell you that the pumpkin seed research came out about 10, 12 years ago. Association specifically for prostatitis patients. I don't know what the action was, but it was good. I don't think pumpkin seed would be helpful for what we're dealing with. It doesn't seem like it would be hurtful. Rebecca says, I drink alkaline water, 8.8 to 9.1. Rebecca, I really, really, really disagree with that. You have to remember that alkaline is just as bad as acid. And, in my chemistry classes, especially my first year when they were teaching us lab safety, what the teacher said is, and I say this, and it's goofy, but this is the way these are the way the science geeks are. Bleach will eat your eyeballs out just as quickly as sulfuric acid. And that's true. If you spill bleach on your hand, it gets very slippery because it's dissolving cells. Bleach is alkaline. Sulfuric acid is acidic. If you're drinking alkaline water every day, all day, you are running the potential of actually hurting your bladder. You want to be pH neutral. I don't have a problem with you doing 1 alkaline water a day, but you really shouldn't be doing more. Elle says, can you have lesions without having blood in your urine? And the answer is they would have to be healed lesions. But guys, I do not believe that you should be drinking alkaline water all day. Okay, now, Facebook, seriously, I do not understand what has happened with Facebook. Yesenia says, I want a glass wand. You can get the glass wands right over on our website. Just go to icnetwork.org. Cheryl says, it's not disabled. Okay, that's good. Hello, Muhassin. Okay, you're saying hi all the time. That's okay. All right. Look, you guys, I can see that we have people who do not understand. Polly, not welcome. This is a support group meeting. Dale, can you email that to me, please? I'm not going to be able to find it here. Dale says the way you make Pedialyte is 1 liter of filtered or boiled and cooled water, 6 teaspoons of sugar, 1/2 teaspoon of salt. Oh, so easy. Cool. John Lee says, can magnesium, pre-leaf, and co-leaf be used together? I have IBS constipation, subtypes 2, 3, 5. Pre-leaf constipates me. I don't know, dude. I mean, I don't know. Yeah, that you're taking a lot of stuff. I'm not a gastroenterologist person. I think you would really need to talk with your pharmacist at a minimum about that combination. I just don't know. All right. All right, you guys. You know what? I think that it is time to switch over to Zoom. What do you think? What do you think? Time to switch over to Zoom so that y'all can talk to each other? Wouldn't that be great? We had a great time last week. So let's do this. We're going to take a 1-minute break. Everybody go pee. Go get your water. Go pee. I need to go use the restroom myself. Then we're going to come back and we're going to transition from Facebook and YouTube over to Zoom, and I will give you the info. All right? I'll be right back. All right. Okay. Right. So hold on a sec. Okay, guys. It's just getting hotter here. Let me pick my hair up and let's do some. All right. Whew. Oh, yeah. Okay. All right. So what I'm going to do is I'm going to put the invitation in YouTube and Facebook, and then I'm going to approve you guys once at a time. And just know when you come into the Zoom meeting, I'm pretty sure you're going to be muted at first, and I'm going to mute you and unmute you because we can't have 50 people talking at one time. So let us, now I'm still new to it. And John, are you here? My Zoom guy. Okay, so what happened to, okay. All right, so hold on a sec. All right, so there's my Zoom meeting right here. And here's my invite. Okay, so we're going to start with YouTube. Lisa, yeah, I'll be staying on live here a little bit. But see, the thing is with Zoom, I can share my screen. All right, so YouTube, there you go. And your pass, and I put the password underneath that. All right, so there's Linnea. Welcome, Linnea. All right, so, okay, there we go.
Hello.
Hi, Linnea. All right, I'm gonna mute you again, hon. Give me a sec. I gotta do this. Okay, on Facebook, here you go. Invitation for Zoom. Okay, Abdullah, there you go. All right, there's your Zoom invitation. There's your password. In the future, we're not going to be doing it this way. I'm going to be a really ruthless guy in terms of shutting people down who try to mess with us. So Suzanne is now in. Hi, Suzanne. Hi, Lori. So you guys, the cool thing about doing Zoom, hi Twyla, is that you're now going to be able to talk, and we're going to be able to work with you one-on-one. Now, remember too that, lots of people are going to be watching this, and so don't get too personal if you don't want to get personal, okay? But it would be, if you want to go to our Zoom meeting and have a chance to meet other people and see other people, that would be great. I see you, Lori. Okay, hold on. Somebody is. Okay. Hi, Marion. Brittany says, any connection between IC and vulvodynia? I've had a few episodes of vulvodynia after yeast infection. Sensitive. Can't help but think there's a connection. Yeah, there's absolutely a connection. The connection is often tight pelvic floor muscles, estrogen atrophy, or central sensitization. That is the connection between IC and vulvodynia. I had vulvodynia before I had IC. I had vulvodynia in high school for years. That all OBGYN just kept saying is, you have the most sensitive skin we've ever seen. You have the most sensitive skin we ever seen. Cheryl says, how do we switch to Zoom? You click on the link, and then you're going to put in the password that I also wrote in there. And I admit you guys one at a time to make sure I know who you are. And we just hang out on Zoom for the rest of the day. I'm telling you, hella fun, guys. It's really, really fun. All right, so Cheryl got it. All right, Cheryl, I don't see it. I don't see it in there yet. Okay, how about you guys over on YouTube? You coming in? All right, Donna, you say you could be doing better. What is going on, my friend? What is going on? You looked so good last week. Are you flaring? All right, again, for people on Facebook, if you can come on into our Zoom meeting, that would be great. You're just going to click on the link that I post. Abdullah says, I have one literature question, which is, That's okay. If you have to download the app, download the app. It's really fast. It's super, super fast. Abdullah, what's your literature question? Yes, you will have to download the app. It's okay. Go ahead and do it. This is the future, guys. We're going to be doing a lot more. Hello, Laura. Hello, Lynn. Hello, iPad, whoever you are. Abdullah, what's your question? You said you've got one literature question, which is, who am I? Could you please analyze? I don't know, hon. All right. Okay, and just know that you guys, I have most of you muted right now, and then I will unmute you. Twyla, what's going on with Twyla? All right. Whoops. 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 Oh, Donna's going to call me next week. All right. Melody says, where is the link? I will give it to you right now. There you go. And let me give you the password. Zoom invitation. There's your password. Your password. In the future, we're not going to be doing it this way. I'm going to be really ruthless, guys. And I know we've got a little bit of a delay. That's okay. Hello, Chris. Chris is coming in. Hello, Heidi. Nice to see you. All right, YouTube. Anybody else on YouTube? If we don't have... Lupita says, my primary IC symptom is frequency, not much pain. I usually urinate 8 to 10 times. 8 to 10 times in a day, or 8 to 10 times at night? Hello, Heather from New Hampshire. Heather, we are just starting our Zoom meeting. So if you would like to come into our Zoom meeting, that would be great. I'm going to be shutting off the stream in the other channels soon so that we can have a private Zoom meeting with that, where people can talk and it won't be broadcast. So guys, couple more minutes, and we'll make the transition. We've been going right now for about 2 hours. But the Zoom meetings are just way, way, way too fun. Got to do the Zoom meeting. Okay. All right. So this way it's going to work. I'm going to turn you guys on. Hi, Jean. Jean, we're switching over to our Zoom meeting. If you would like to come join us over on Zoom so that you can talk, that would be awesome. There's the link. There's your password. Come on over. Hi, Sue. I'm going to let Sue in. All right, you have your cameras turned off. Now, half of the fun is turning on your camera. Okay, and don't forget on Zoom now, you have an area where you can chat. Will this be the same link every time? I think so. I'm still Guadalupe. Welcome. Huawei. I don't know who you are. I'm going to let you in. John, give it a shot, dude. Give it a shot. Did you just download it? I'm sorry. All right. Okay. So we're officially transitioning over to Zoom. And so what I'm going to do is I am going to turn you guys on one at a time, and let's see how you're doing, if you're having a flare, and if you've got any questions. All right. And so I'm still simulcasting on Facebook and YouTube right now. So just remember that what you say is going to be heard by others. So if you value your privacy, you know, you don't have to say certain things. So the first person I'm going to go to is Heidi. Heidi.
Hi.
Hey girl, how are you?
Good.
So how are you feeling today? How is your IC?
Good.
Love it. I love your background. Are you living down in San Francisco, in the San Francisco area? It's just nice and calming and soothing for those of us that it's hot here. So what subtype do you think you are?
2.
IC subtype 2, bladder wall injury. Okay. And what is working for you? You're in good shape. What do you think's working for you?
Hydrodistensions.
Okay. How often are you having hydrodissensions?
About every 5 weeks.
Ooh, that's a lot. Really? Now that's actually pretty rare. It's pretty rare that you would find a doctor who would do it that frequently. Is that being done in a hospital, or is it being done in your doctor's office?
Hospital.
Okay. Okay. And if we took a step back from the hydrodistensions for a moment and asked ourselves, what is physically wrong with your bladder? Do you have Hunner's lesions?
Actually, I don't know if I can show you a picture of it.
Oh, awesome. So you guys,
yeah, I see them.
For people on Zoom, you should be able to see what she's going to show to the camera. So let's see what you got. Can you get rid of your background? Get rid of the Golden Gate Bridge in your background for a moment, so we can see that picture.
Oh, good question. I don't know how I got it on there in the first place. Let's get closer. Can you see it at all?
No. What's happening is the color matching.
It's fighting it.
Yeah. Okay. So basically, what I'm seeing is wide, pale pink swaths with a couple of darker red areas, but nothing is red and bloody. It's pinky.
He got it that way. It was flaming red.
Okay. Interesting. And how many hydrodistensions have you had?
Multiple.
And you're in Michigan?
Yes.
Have you
gone? It's Dr. Peters.
Oh, so it's Dr. Peters doing it. Interesting.
Yep.
Well, you couldn't be in better hands. I mean, he's just an.
I know. I did send you the question, but I fell asleep. It says on my pictures to consider cyclosporine.
Right.
And my bladder capacity went from 550 down to 500. That's why he's doing them.
Okay.
I'm losing bladder capacity. I was at 300.
So are you going to do it or not? What do you think with the cyclosporin?
That is an immunosuppressant drug.
It is.
Nurse, I'm like, I'm heavily cautious at it. I don't know.
I think it would be absolutely reasonable to wait 6 months, and let's just see what happens with COVID, because it would make you more vulnerable to COVID. And as you know, Michigan has been hit hard by COVID. Hit hard. Yeah.
He is switching out my inner stem.
Okay.
In July to the new one.
Okay.
Smaller, MRI safe.
Right.
And I charge it with a pad.
That's cool. That's cool.
Yes.
Well, I think
Other
you're, you know,
medications-
I'm sorry, say that again?
I'm sorry. Other than that, I'm not on any medications.
You're not what? Say that again?
On any medications.
Okay. And how's your diet? Are you able to eat well? Are you still
Yeah.
are you watching your diet carefully?
I am. Mine is stress triggered.
Yeah. Yeah. So's mine. Mine can be very, very stress triggered. No doubt about that. And well, I listen, hun. I want to send you all that I can. The good news here is that you're under the care of one of the best doctors in the world. If I were close to him, I would absolutely be seeing him myself. Ken Peters, the chairman of the urology department at Beaumont Health in Royal Oak, Michigan. We send a
Yep.
lot, yeah, we send a lot of patients up to them. And everybody, please know that urologists like Dr. Peters are facing tremendous stress right now because of COVID. They're losing colleagues. Beaumont lost at least one doctor to COVID. And so anything that we can do to support those doctors. What I say in my magazine, literally, and let me I just want to, in my article, I have an article on this, on getting through COVID. And I say, last but not least, please remember that your medical care providers have been through hell. If they are caring for COVID patients, they often don't go home or they isolate from their family for weeks. That they've had to make the most difficult decisions in health. Many doctors, nurses, and staff have died in service to their patients, and they too are worried. So let's show our gratitude as frequently as possible to them and to all of our first responders. And so please, guys, our doctors are not our enemies here, and they need lots of love too. It is going to be something they're going to carry with them for the rest of their lives. So, all right. Thank you so much. I'm going to go ahead and mute you now. And let me just see here. Laura. Hello, Laura. Hi, hun. How are you?
Hi, I'm fine, and you?
You know what? Aside from being hot and I feel a little bit better now. I'm okay. How is your IC today?
I think it's controlled.
Okay, so it's going pretty good.
I have been in with IC since 2016,
Okay.
and really things didn't work so good with all the installations that my doctor made.
Okay.
I think that I live in Colombia, so I think here there is no information or investigation about IC.
Right.
So
Right.
finding your support group was very important to start searching for the right subtype for me. I have also fibros, so I think I have yours too, the central sensitization, I think it's called. But I don't know if I have a Horner's lesions or I have subtype 2, the one of the wall
Okay.
of the bladder.
Okay.
So I really don't know what to do.
Well, so this is where the internet is your friend. I mean, this is where when you live in a country where we just don't have a lot of icy stuff happening, you get to bring the best of the world to you, and you also get to bring the best of the world to your doctors. You know, when I started the IC network, I wanted to bring the world's best to you at your home so that you could educate the people around you. And what you're going to need to do is print out the American Urology Association guidelines for IC. And I will, if you email me, I will send you the link to that. It's going to be important that you print that out, and you print out 3 copies, one for you, one for your regular doctor, and then one potentially if you ever have to go to the emergency room, so that you can give them doctor to doctor what they're supposed to do. And it's not you getting information from a random girl on the internet. It's you getting information from the largest urology association in the world. And you know what? I can share my screen. Wait a second. Okay, how do I share my screen? I can just, okay, hold on. Wait, I got to figure this out.
Okay.
How do I do this? Okay, I figured it out last time.
Really, I don't know.
Okay. Oh, here it is. Here it is. Okay. Okay. So hold on a sec. Let me just clean up my screen here. Okay. So I'm going to share my screen for a moment. I'm going to share my desktop. Okay. So can you see my owl?
Yes.
Okay. So for everybody watching, go to your web browser. Whoops. Hold on. And I want you to go to AUAnet.org, the American Urology Association. So it's AUAnet.org. Yeah, oh, all these privacy notices. So this is what we want. We want to be on the American Urology Association website. Okay? So that's AUAnet.org. Then over here is guidelines. Click on guidelines. So it's the medical associations that create treatment and diagnostic guidelines for medical conditions. So now we're on the guideline page. You're going to go down here to search, type in interstitial cystitis. And here we go. We have the IC guidelines. Diagnosis and treatment, IC bladder pain syndrome, 2014. They're going to be revising again the next later this year. And there is so the thing about these guidelines that's just so important. If you look I'm using my finger, like you can see my finger. Oh my God. So the way they have this set up is in there's an introduction, presentation and diagnosis, guideline statements, and then they go through all the treatments that should not be offered, etc. And I think if you click on this PDF, unabridged version, yeah, so it just downloads the guidelines right to your desktop. So let me let me go there. Oh, see that mouse drives me crazy. Here we go. There you go. So for everybody watching, you know, this is the one document that you can hand to any doctor to shut them up if they're telling you this is not real. This is from the top urology association in the world. And what I want you to do, so it's set out in statements, 3 statements. Diagnosis, the basic assessment should include a history, exam, lab exam, right? And then treatments, it talks about treatments. Pain management, it wants pain assessed compassionately at every single appointment. So it summarizes it here, right? So there's a quick summary. Treatments that should not be offered, long-term oral antibiotics, high-pressure distensions. Yeah, I'm using my finger again. And then you can go into and read the rationale they use. So this is going to be your best tool. And anybody in any other country, if you hope, as long as they don't have a grudge against the United States, which is possible at this point in time. I can understand why. That resource will get you farther than anything else. So that would be number one. And you can use that to request perhaps a hydrodistension if you think it's warranted. Now, listen, Hunner's lesions are painful. So most people with Hunner's lesions, they will often have blood in their urine. They're down to eating 4 to 5 foods, 6 foods. They have flaring all of the time. And so visible blood in your urine, if you're peeing blood clots, that's when we definitely want somebody to look in your bladder to try to figure out what is bleeding. Sometimes when you bleed, it's just infection. Other times when you bleed, it's injury. It can be injury too. And so getting eyeballs on your bladder, letting somebody look at your bladder is important if you can find the right person to do it. I would suggest that you look at the Columbia Urology Association. There's got to be a group of urologists in Columbia. And guys, be bold. You can call anybody you want to call. If there's a national organization, call them and say you are looking for a doctor who can help you through this diagnostic process and ask for a workup, and they should be able to do that. The other thing too is that a lot of international doctors are willing to work with doctors in other countries by phone. And so if your doctor doesn't know what to do, there's a chance that he could reach out to one of the top doctors and get some help. And in the meantime, it's in your best interest. Is your pain the worst as your bladder fills with urine? Or is your pain worse before you pee or after you're done peeing? When do you feel the worst? All the time.
Really, all the time.
Is there, does it change at all during the day?
I have moments where I don't have pain, but it could be all the time. Before I have to pee when my bladder is fully, when I pee all the time, really is.
How about in the morning? When you wake up in the morning, is it bad?
It's not that bad.
Okay.
When I wake up.
Okay, so in other words, it gets worse as the day goes on.
Yes.
Okay, and I don't want to ask you an embarrassing question, knowing that people are watching this.
No, you can ask.
Are you having normal periods?
Yes.
Okay.
Normal periods. They're very long and painful, but normal.
Okay, so when you try to urinate, can you start your urine stream right away? Or are you hesitating 5, 10, 15, 20, 30 seconds before you can pee?
No, I can pee immediately. I don't have to wait to pee.
When you go to your gynecologist to have an annual examination, do you dread it because you know it's going to hurt? Or do you not normally?
I have vulvodynia too. I have vulvodynia too.
Okay. So that's important. How old are you?
I'm 28.
Okay. And when did this start for you?
In 2015, I think.
Okay.
So it started in the bladder, and then in 2018, my gynecologist said that I have vulvodynia.
Okay. So I had vulvodynia in my 20s too. And you know what, guys? Okay, so we've still got people watching on YouTube. We still got people watching on Facebook too. All right, I'm going to keep those up a little bit longer because we're just going to keep going through this. And I wish Facebook I could switch over to screen share. Hold on a sec. I don't think I can. No, I can't. So 5 years ago, you were 23 years old. So what was happening 5 years ago?
I was studying to be a lawyer. I'm now a lawyer.
Okay.
And
Congratulations. It's awesome.
thank you. And I was finishing the university. That's what really was happening in that time.
Okay, so we know you were sitting for long periods of time studying, right?
Yes,
Okay,
I,
so
I had UTI. Is all it starts when I had this UTI. I take a lot of antibiotics, and after that, uh, all the tests were negative. So I started looking for other doctors, and finally, one doctor that was the one that diagnosed me told me, make me a biopsy, a cystoscopy with hydrodistension,
okay.
and a biopsy. And there in that time, he told me I have IC based on the cystoscopy.
Okay. Okay. Well, we have to remember that the bladder wall can be broken down. It's not just potentially chemical injury. I mean, you're the only one who can look at your diet and ask yourself, was your diet absolutely terrible? As a lot of people are when they're in school, they're drinking
No.
massive amounts of coffee and monster drinks and high energy drinks just to get through the process. So, I mean, there is a chance that perhaps your bladder wall was injured to some degree, but I think that there's also a chance that your muscles are involved, if not just for the fact that while you were in law school going through this, you were sitting for very long periods of time. And when you sit, you know, you're changing blood flow. They call sitting the new smoking because it can be so damaging to the body over time. And we all know that there are some chairs that you sit in that your legs start to tingle because the edge of the chair is pushing up against the veins in the back of your leg and it's starting to limit blood flow to your legs. So, and the fact that you've had a little bit of pain with intimacy is interesting because it might be a little bit suggestive. What's ruling against that is that you can pee right away. I guess the other thing I'd want to know is since you said you feel better in the morning, it gets worse as the day goes on. Is there any chance that you could have fibroids? Is there any chance that you might have some endometriosis? That
My doctor, like 2 weeks ago, my gynecologist suggested that I could have endo.
ah
So I'm now looking for for that,
okay.
but I don't know, based on the results of the biopsy, if I have to make something different with the supplements, more installations, or
Well,
anything
what
else.
treatment was he offering you? What treatment are they offering you at this point in time?
Uh, like 2 months ago, Elmiran
Okay.
was the suggestion, but like with all the studies about the eye problems and renal problems, I don't want to take that because I have like fibromyalgia,
Well,
vulvodynia. So
okay. So if you can instead look for I mean, I don't know if we send to Columbia, to be quite honest. If you can go to your store and look for a good chondroitin glucosamine supplement. It's the chondroitin that's the most important because chondroitin helps to restore the integrity of the urothelial cells on the bladder wall. So look for a good high quality product that contains chondroitin. Also look for the source. Chondroitin generally comes from cow trachea or shark fin, and those are both pretty bad. We want chondroitin potentially from chicken, from pollo, right? And so we don't want to support the shark fin industry because it's just killing millions of sharks. And cow trachea is banned in Europe because of the risk of mad cow disease. So they send Europe sends their cow trachea to all the other countries. So look for a chondroitin that comes from chicken if you can, or look for there's apparently a vegetable source of chondroitin. I don't know what the actual source is, but I think that's what I would do. That would give you perhaps something a little bit similar to the bladder coating effect of Elmeron without you having to worry about that. You could also ask your doctor if they would do a heparin lidocaine installation in your bladder wall. I mean, through a catheter. It would be interesting to see. We call it an anesthetic challenge. If putting lidocaine in your bladder made all of your symptoms go away, then that tells us this is really bladder wall driven. And then, last but not least, I don't know if it's possible in Colombia or not. Do you flare when you eat sugar? Do you feel worse when you eat sugar or carbs?
No, I think that with acid foods, yes, but with the sugar, no.
Okay, because for somebody who flares when they eat a lot of sugar, that really points to candida infection. And so it's just same as when you make yeast bread, you prepare the yeast by putting it in warm water and sugar, and it starts to bubble. Well, if you've got candida in your urine and you eat sugar, the yeast starts to grow and can trigger more pain and discomfort. So that's good. It's good that you're not flaring with sugar. But I think that's what I would do to start. And then I encourage you to read through the AUA guidelines, give your doctor a copy of that. And it would be interesting to do an anesthetic challenge just to see if it turned the pain off. But I would also think it'd be very interesting to have a pelvic floor assessment just to see what the health of your muscles are. And right now, we're still guessing, and we want to try to make treatment decisions based upon actual findings right now. And so we know one thing: he did a hydrodistension, your bladder wall was red. That's all we know right now. We know that when you eat certain foods, you flare, but we don't necessarily know the physiological reason why that's happening. And so, could it be endo? Possibly, but I have to. I don't know. I mean, I would really want to know what's going on with your muscles right now, since you also have the vulvodynia. Because I realize in hindsight, every time I've had vulvodynia in my life, I had major vulvodynia for several years in high school and college. And then again, last year, it was all muscle driven. And so I have to wonder, hun, okay? So keep me posted. You're welcome to email me, icnetwork@mac.com. If I can help your doctor connect with some of the top American doctors, I will absolutely do that for you. And we'll see what we can do to get you some better care, okay?
Thank you. I really appreciate it.
You are very welcome. And you are absolutely not alone, my friend. We see IC in every country. And the good news is you've got the internet, and we're going to get some good resources to you, okay?
Thank you.
Okay.
Bye.
All right. I'm going to mute you now. And now we're going to go to, let's see, Lori. Lori on her iPad. Hold on. I've got to unmute Lori. I'm trying to unmute you, Lori. Hold on. Let's see. Oh, there you are.
Hello.
Hello, my friend. How are you today?
Not too bad. Today's not a bad day, which is good.
Hey, hallelujah, baby. We're going to take the good days with the bad days, right? We want more good days.
That's right. There hasn't been very many good days.
Well, we're in a weird time.
I was diagnosed with IC 10 years ago.
Okay.
I take Elmeron, which is interesting. I have a new doctor because mine retired.
Okay.
And I had a hydrodistension in 2014 that did fabulous things for me. That and Elmeron, I went months without any major flares or any being uncomfortable.
Okay.
then I ended up having a lot of, I think you referred to it as a bladder installation. My doctor calls it a bladder rescue.
Okay.
I was having them like for a year, like every 3 or 4 weeks.
Okay.
So I had my urologist did a cystoscopy with hydrodistension on Halloween.
Okay.
And unfortunately, the anesthesiologist only gave me propofol, and they could not get my bladder to the point where it could be distended enough without me waking up.
Ooh.
I did not remember that, but that's what I've been told.
Okay.
So that lasted a few months, and now I have a new doctor, and I don't trust easily. I'm also in Michigan.
Okay.
I don't trust easily, and I met this gentleman one time and love him. And I am scheduled to have a cystoscopy with hydrodistension again on the 27th of May.
Okay.
Which right now, and which is also very interesting, he is going to discontinue the Elmeron after the procedure because he doesn't think it's really doing anything.
Okay.
So I've been on it for 10 years. So I'm going to do what he says. I feel like I trust him.
Okay.
The last hydrodistension, they could only get 300 cc's in, but that was because of the anesthesia situation.
Okay.
But I I was looking at the report, mucosal hemorrhages.
Mucosal hemorrhages. Okay.
Yes. Yeah.
Okay.
Yeah, which I'm not sure I know exactly what that means. But.
Okay. Let me explain the anesthetic situation. The reason why they use propofol is because it doesn't deaden the nerves to the point that you can't pee for 12 hours. And so the cool thing about the propofol is you go under very quickly and you get out very quickly. And so
that was true.
I remember when I had my DNC, and I was waiting to go into the OR, and the anesthesiologist came out to talk to me. I just said, "Listen, I need to be able to pee afterwards.
Right.
And this will be a success for me if I can pee within 20 or 30 minutes." And he's like, "I know exactly what to do. I'll just give you more propofol and less of the other." And it's like, hey, power to you. That's exactly what I want. Because when I had a laparoscopy for my IC in September of 1993, I could not pee for 12 hours, and they sent me home unable to pee. And it was terrible. And so propofol, even though, yes, it did kill Michael Jackson, it is an incredibly viable anesthetic for various procedures, guys. So don't be afraid of propofol. It's an absolutely wonderful way of having anesthesia. Opinion for somebody who has pain, empty your bladder quickly. I think it's pretty important. But clearly for you, you probably had, did you have Hunter's lesions or not? You just had the mucosal. Interesting.
Yep.
That's interesting. Yep. I don't know. I don't know. I mean, that's,
Now I had endometriosis from the time I was 17 till I had a hysterectomy when I was 38. I'm 52 now.
Okay.
So, and I had many, many problems. They punctured because my everything was our tissue. So I had a lot of trouble with my bladder. After that, I don't know if that has any play in any of this, but it's pretty uncomfortable. And I guess I would say if I had to self-diagnose, I would say number 2, because I'm like you. You put 100 cc's of anything in there, and I gotta pee.
Okay.
And I gotta pee right now because the pain is horrific.
Right.
So that's basically my thing.
Did you have 10 years ago, were you having normal periods? Did you have a hysterectomy? Anything weird going on 10 years ago?
my goodness, 10 years ago, 2010.
I mean, when this all started, I mean, I just wonder if there's a hormone connection to some degree. I mean, you know, you are in your 50s, you know.
Well, yeah, because this didn't start till, I would say maybe 8 months after problems, but you know, you got to get somebody to listen to you then, right?
Yeah.
And then I found the right people. So I would say my hysterectomy was in 2006. So it's very possible because they left the right ovary.
Oh yeah, girl. Yeah. So yeah. So this is probably hormonally driven for you in the sense that you lost 50% of your estrogen supply when they took that ovary. That this means that, you know, I mean, I'm not saying this is an absolute what's the right word? Not correlation, but let's just say you only had half of the estrogen you used to have. Therefore, your bladder wall is not 100% normal. It's not as thick and robust as it would have been. It's now half of what it would have been 10 years ago procedure. And now your estrogen levels are just getting lower. And so you're getting your bladder wall is just getting more and more. Not a disease process, that's estrogen atrophy. And that, you know, I mean, that puts you really solidly in this group. So are you using any estrogen creams, topical creams, anything at all like that?
Nope.
Well, that might be the missing link here.
Okay.
You know, if you can go to your gynecologist or go to your urologist and have them look at the quality and health of your skin. If your vulva is and the vulva and the vagina are really, really, really easy to identify when they're in estrogen atrophy. Apparently, they get kind of these horizontal lines in them, and the tissue gets very, very thin. In IC subtype 2, genitourinary syndrome of menopause, also known as estrogen atrophy. That's a guess. So let's get to the doctor, see what they have to say about the quality and health of your skin. And just know that when you give that skin a little bit of estrogen, it's able to produce mucus and it becomes thicker and more robust. I have a really good video on our website called the Estrogen Chat. I would encourage you to watch that. You're not taking oral estrogen where it goes through your bloodstream, where you are running a much bigger risk of breast cancer and stuff like that. Topical hormones tend to stay in the tissue and are considered much, much safer. So I would suspect, hon, that's I bet some good money on it, but let's see what the doctor has. I'm admitting Lisa and admitting somebody else here. All right. Okay, hon.
Thank you.
You are very, very welcome. Becky.
Hello.
Hello, Becky. You just look all cozy and comfortable.
I'm relaxing a little bit.
And I'm in envy of your mascara right now. If those are your natural eyelashes, I'm in envy of you. You look beautiful.
Oh, thank you. I have makeup on, but it's a new mascara. It's from a brand called Thrive.
Nice.
Yeah.
Nice.
Look
at that. God, it's beautiful. All right, hon. How are you feeling today?
I'm okay. Somehow like doing okay because I'm not going to work, so I'm less stressed than usual, even though everything that's going on. So I'm doing all right, and you know, I had a food related flare, and that lasted about 2 weeks, but it's kind of over now. But I just really miss going to physical therapy. I feel like I'm having a lot of pain and muscle pain and tightness. You know.
Mm-hmm. Are you using your wand?
So I have one, and I'm like,
it's weird, isn't it?
Yeah, and I don't love it. The other thing is, I have this like lump. And it's so weird to talk about, but you know, we're all going through the same stuff. I have this weird like lump on the right side of my vaginal opening, and I think that it's like a muscle knot because I've had it on and off before, but then at the same time I can't be 100% sure that it's not like a cyst or a tumor, and I'm sort of afraid
Is
to
it is it
press on her around
is it
it.
growing? Is it
Um,
getting bigger?
I can't fully tell, I mean, it seems to me like it is, but it's not visible, but I can feel it.
So,
So,
this is where I get to say, have you looked at it?
no.
Okay. Okay, my friends, my friends, my friends. Now listen, there comes a point in time where you got to pull out the drawer in your bathroom, put a mirror on top of it, and squat over it and look at your body. You just got to get comfortable with that because there's look at the laughing. Hey, now listen, we got to be brutally honest here. Come on, everybody at some point in time has had a little pimple down there, and you just have to look at it, right? So how do you look at it? You pull out a low drawer, put a mirror on it, just squat over it. You know, you have to know your body. You have to know your body, and because over time as things change, you're not going to be able to tell your doctor if this is normal or abnormal. What is its texture? What is its texture? Is it smooth? Is it bumpy? Does it have a texture to it? Tumors are normally not particularly smooth. Well, I mean, when you actually are at the tumor, but over the skin would make it smooth. So let me take that back. I don't know, hun. You got to have it looked at. You got to have it looked at. Is it shallow, right at the entrance to your vagina, or is it inside your vagina?
It's like right at the entrance, like kind of on the outside, I guess.
So it could be. It could be you could have vestibulodynia. There are two little tiny glands right at the entrance to the vagina. Mm-hmm. It sounds like you probably have a little infection to that. Infection in one of those. What they do is a Q-tip test, and they touch them. And if touching it hurts, then it's vestibulodynia, something like that.
Yeah, I think I had a gynecologist that mentioned that he thinks I have, I think he called it vestibulitis.
There it is. That's it. That's it. Yeah, that's it. So I have a very good family member friend who has a fairly wicked vestibulitis. And it would flare a couple of times a year where that little gland becomes very swollen and tender and irritated. And she would do a soak of, it's called Great Mother's Sit Spaz. And let me see if I can find it. Hold on. And this is what she swore by. And we used to sell them on the IC network. Hold on. Let me see if I can find this. Is this it? Hold on. Okay, I'm going to do screen share again. So hold on a sec. Oh, wait. Yeah, hold on. Wait, I can't screen share. Okay, now I'm going to do screen share. Okay, there we go. Allergies are a beast right now. Can you guys see my screen?
Okay. Oh, now I can see it.
Okay, so y'all see the owl. Okay. So this is a company called Great Mother's Goods. And they have this, I wish I could. This is, And look at how small their pictures are. Isn't that sad? Imagine a really big tea bag. And what it is it's filled with plantain, comfrey, calendula, marshmallow root, yarrow, and sea salt. And you get so like a tea bag, it turns brown. Because as soon as you put it in the water, the herbs inside stain the muslin. But you can get like 3 baths out of 1 bag. And this is often suggested for women who have they've had episiotomies after having a baby, or they've got extreme vulvodynia. And so anyway, this is how I learned about this product, was from this staffer, family member, friend, all of the above, who used a Great Mother Sitz Bath for her vestibulodynia, and it worked like a charm for her.
Well, thank you. I will check that out. I took a screenshot of that.
Yeah, so Great Mother's Goods, and it's called, anyway, Great Mother Sitz Bath. Uh-oh, hold on. Did somebody else just come in? All right, I just muted somebody real quick. Hi there.
Well, thank you.
Hold on 1 sec. Okay, Becky. Well, listen, carry hope in your heart, my friend, and you are absolutely not alone, okay?
Thank you.
And
I really appreciate you so much.
You're very welcome, and say hi to your husband who just walked by.
Yes.
And tell him thank you for being there for you.
Yeah, he's.
Uh-oh, I just muted you. Okay, bye-bye. All right, so hold on a sec. Hey, Suzanne. Hello, Suzanne.
Hi, Jill.
Hey, hon, how are you doing today?
I'm having a bit of a flare today, so I'm in bed and having some chamomile tea, which is excellent for that.
Excellent.
And,
excellent.
Wow, I'm talking to the fabulous Jill. I don't believe it. I feel better already.
Well, honey, it is. I'm just like you. You got to remember, I'm just like everybody else. The only difference is that I made it a lifetime's work, and so I read about this all the time and talk with a lot of patients and all that sort of stuff. So how long has this flare been going on?
Oh, it's just been going on for a few days because I just haven't been feeling well, and I tried to take some Advil.
Okay.
And that has always an adverse effect, but I've got back pain that I have to deal with too. So some days you just got to do it, like you said. If you just can't take it anymore, just go ahead and do it. So I'm just going through the circumstances of that, and it's okay.
Okay.
I'm in bed. It's all good. I'm a grandma. I afforded lots of time to just take care of myself, so I'm very grateful. I have to say that I'm not even on a scale of 1 to 10. I would say I'm probably around a 6. Okay. And seeing everybody else's pain, 10 or more, I feel very grateful. I'm blessed not to be in as bad a shape. But I'm 66 years old. I was diagnosed a year ago. It just showed up. But I believe now, after working on this and doing research over a year and following your weekly groups, I think I'm like Lori. I think I'm the estrogen atrophy.
I think so too. Normally that's what we would see in somebody who presents after you reach a certain age, and you look absolutely wonderful for your age. I'm gonna be 60 this year. Like, whoa, how the hell did that happen? It's so weird. I feel 25. I do not feel my age at all.
I do too, and that's why my husband and I retired out here to Portland, Oregon 5 years ago, and we were just so looking forward to getting on with our dreams, of being out here. And I lost my only child 22 years ago.
Oh,
He was 24. So spent many years trying to dig myself out of that hole.
right.
And I feel like I'm above ground now. That's about as far as I've got. But
Yeah.
this was just came on a year ago, just like out of nowhere. And my urologist after cystectomy said, I didn't say that right, I'm sorry.
No, you're fine.
She said, well, I see, you have interstitial cystitis. And I go, oh. Now, I'd done all the internet searches before that and was afraid to death to have a test because I just felt in my heart that was what was going to be.
Right.
And she said, so now what do you want to do? Now what do you want to do? And I'm like, are you kidding me? What the fuck? Oops, sorry.
No, it's fine, hon. You're entitled to swear. It's okay. I got no problem with that.
She just came into into the room after it was over, and it was a very good test. And she said, now what do you want to do? Now, what my question would be, she never explained what it is she saw because she said, I don't know what that is.
Yeah.
I don't know what that is. And it was just a little small red area. I don't know the size of your bladder or what what the size would look like.
Right.
It was just a red spot. It wasn't bloody red. It wasn't anything. And I said, that's what's causing my excruciating pain. Are you kidding me?
Yeah.
I can only imagine what it's like for other women. I have no reason to complain, but at 66, it gets harder on the older women. It's just like, oh, everything gets harder.
So just understand that it would have been nice if he'd said, "Hey, you have genital urinary syndrome of menopause. We see this in women
Didn't
of a
have
certain."
any idea.
Yeah.
No, she didn't say anything. She said, I don't know what that is. So what do you want to try and do? Well, before I was like, well, I guess what I'll try and do is I'll try and do the diet. I said, do you think I'm in better shape than most of your patients? And she said, yes, I think you'll recover. That was a year ago. I followed the diet, which is pivotal. I mean, that is crucial. I've tried everything. That bladder builder, I couldn't take that because chondroitin makes me sick. Gives me nausea. I'm on the aloe vera, which has saved my life.
Okay.
It's amazing.
Okay.
I went to my regular doctor. He goes, Susie, I have no idea about IC. I know nothing about it. And I'm thinking about getting that book and taking it into him. But I'm like, you just feel like, okay, I'm on my own. Without this support group, I wouldn't know anything.
Right.
So I'm one of those dreaded patients that come in and say, well, I did a little research on my own. And they hate that.
Oh, yeah. Yeah.
And hate that. So
yeah.
I have a list of things. I said, I'm not going to go till we go through this list of things. You provide a service. I'm paying for it. So there you go.
Yes. Yes. That's exactly the way I want you to work with your doctor.
I am. And I am not. Now I'm waiting to get into a urogynecologist. I'm not even going to mess with a gynecologist. I haven't seen one in many years, but I had a hysterectomy back in 93, left with one ovary like Lori.
Yeah.
And I believe I have all the symptoms of the atrophy, the estrogen.
I think so too. And so are you using any topical estrogen, anything?
No, I did back in my 50s just so I could have sex with my husband, but that's been over for.
Yeah, but girl, listen, I have worked with some women in their 80s who their vulvas become like dry, agonizing potato chips. I mean,
girl, I took a good look in the mirror and I was horrified. I was horrified. I go, what the frick happened? I can't. I don't want anybody to see that. Not even the gynecologist, but but when I had the exam with the urologist, my pelvic floor was in great shape.
Yeah.
She said, you're in great shape. It's just that filling of the bladder, and it's excruciating.
Well, that I think, hon, I think that estrogen atrophy is I think that there's a very, very good shot that it's estrogen atrophy. So doing something that has a coating effect to protect your bladder makes sense, along with
Yes.
using perhaps a topical estrogen that will allow your body to start producing more mucus makes the most sense at this point in
Yes.
time. And understand too that you might be more prone to getting infections because you're dry down there. But the good news is you did use estrogen a little bit, so you're not bone dry.
Yeah.
But you got to be on that. Let me just give you my
Me
comment
too.
on estrogens. Premarin is the topical estrogen everybody hears about because they've got these big fancy TV commercials. Premarin comes from pregnant mare urine. It comes from horses. It's a despicable, disgraceful industry where they keep these horses pregnant, kill the babies, and I refuse to support that. But more importantly, Premarin has a lot of extra chemicals in it, and it's known for causing a lot of extraneous burning after the fact. Using a compounded preservative-free estrogen cream is much easier on the body. You don't quite have the chemical sensitivity that you used to have. But for anybody out there, listen, if you use estrogen and it burns when you put it on at first, well, yeah, you're dry. Yeah, there's no coating. Anything you put on that tissue is probably going to burn, right? Even because this applies to the vulva and the vagina too. I mean, you've got a mucosal layer, and then you've got skin cells under that and that. And so when you don't have, this coating, putting that topical cream on is going to be warm. So when I first started using it, it was very hot for about 10 to 15 minutes, but over a period of 2 weeks, the heat got less and less and less as my body was starting to use that estrogen to produce mucus. And now when I use it, it's like a little warm puff of air. And anytime it is more intense burning, it's because I just haven't been using it correctly. I can be very passive aggressive about, I just can be about my pelvic floor and about my estrogen. And I will sometimes go a week or 10 days before I remember to use it again. And it's always going to be a little bit hotter then because my mucus, has gotten thinner. So, picking your choice is important. Well, listen, hon, thank you for sharing your story. I think you should carry hope in your heart. There's nothing here that disturbs me to any great degree.
I have a wonderful husband. I have a wonderful family that supports me. And now these days I can get out of anything that I don't want to.
Well, that's, kind of like one of the gifts. Also, listen, since pain is a bit of an issue for you, you really should think about trying the Peora.
I'm going down. I'm kind of going down the list.
Yeah, go down the list, but there's no chondroitin in this. It's just the palmitoethanolamide and the resveratrol. And the research study with IC showed that this combination was really successful at reducing pain and discomfort. And so, significantly at 3 months, 87% of patients using it had a significant reduction in their pain. So it's a viable option that is worth consideration. All right.
Yes, absolutely. You take care.
You too.
You take care. Be safe. Be well. Bye-bye.
Yeah.
Bye, everybody.
All right. Now, hold on a second.
I'll go to the bathroom.
Now I gotta mute you, but I gotta find you here. Hold on a sec.
Yes. I was talking to Jill.
Oh.
Say hi.
Hi, Jill.
Hi.
I heard you say wonderful husband. And I was wondering who you were talking about.
Love it. We love our partners. We love our husbands. All right. All right. Guadalupe has her hand raised. And but I can't see a picture, so I don't know if this is going to work. So Guadalupe, and it won't let me unmute. All right, Guadalupe, if you can just go into the chat area and type your question there, because I am not successful in unmuting you. Hold on a sec. Where is Lisa? Lisa Frampton? Are you still here?
Hi.
Hi, how are you?
Good.
Like isn't it great to actually attach a face to a name?
Yeah, it totally is.
Because I am so familiar with your name, and to be able to actually
Yeah,
see you. How are you doing today?
I'm doing all right, best as
Okay.
I can, right?
Yeah. Yeah. How's your IC?
It's not been as bad the last few years as it was previously.
Okay.
Um, I'm on a heap of medication, like usual.
Okay.
Um,
Like what? What are you taking?
Gabapentin,
Okay.
Cymbalta, diclofenac, Celebrex. I can't remember a bunch of thyroid medications.
Okay. Well, what subtype do you think you are?
Honestly, I don't know. I know that when I got diagnosed, I had Hunter's ulcers.
Oh, okay. Okay.
So, yeah, I would, whenever I'd have a flare, I would, pee blood. And when I had my second to last child, I told them to use a pediatric catheter on me because it was an emergency C-section. And they refused. And so they got a big one and they couldn't even get it in there. And then they kept shoving it in. My bladder was spasming. I'm like, my bladder's spasming. They're like, how can you tell? I'm like, oh my gosh. So they put it in there like, oh yeah, your bladder's spasming. I'm like, duh. But I bled for days because of that. It was horrible.
Okay.
And then, I suffered for a long time after that. It took a long, long time of watching my diet and being really careful, trying to control emotional stressors because I noticed that would always put me into a flare.
Right.
And so when I learned to have a little bit more of a handle on that and going to therapy and stuff like that, I've been able to get, my IC under a lot more control.
Okay.
I just have to make sure I use the bathroom regularly because I'll forget until I have to go so bad that there's so much pain I can barely walk.
Okay.
Aside from that, I'm doing pretty good. I think that I'm in a type of a remission of some sorts. So it's been lovely.
Okay. Love that. So, but the question here is, what is the status of your Hunter's lesions? I mean, have they been treated? Because girl, you're taking a lot of meds, and I'm not saying that's a bad thing, but we always kind of try to want to understand the anatomy that's driving the need for that medicine. And here's what we know. Untreated untreated Hunter's lesions are well known for triggering severe, long-lasting chronic pain. And so, have your lesions been treated?
I never had them treated exactly. I moved out of the area where I had a really good urologist, and I moved to Tennessee and couldn't find a urologist or anybody that could help me. And I've moved back, and since then, my original urologist he's not practicing anymore, and I haven't been able to find one since.
This to me is really, really important. This is that situation where, you're on several medications to reduce pain. And it's the pain patient that is the one they're the ones that are being the most severely affected by the opiate crisis and being denied pain care, because there's no doubt you're in pain. There's no doubt you are and that you have been in severe pain. And the American Urology Association understands that, admits that, accepts that, and wants pain assessed at every single appointment. Because we know that pain left untreated can do long-standing damage neurologically to your system. It's like fighting a fire, right? If the fire is in a cup, we can pour a little bit of water on it, make it go away. If I let the wall catch on fire, the drapes catch on fire, it's going to take a lot of water to turn that off. God forbid my house burn down. Fighting pain is the same way. You have to try to catch the pain early. The people who really suffer are the patients who don't use their pain meds correctly. They wait until they're crying before they use pain meds. And the whole principle behind pain medication is trying to stay ahead of the pain. We want to try to stay ahead of the pain, nip it in the bud early so that the nervous system does not get really involved and that it just blow way out of proportion. But the challenge here is that you have the number one thing which causes severe bladder pain. You've got Hunner's lesion. And until those Hunner's lesions are treated correctly, you could be in this for the long haul, and we don't want you to be in this for the long haul. We don't. If we know, it's. I'll tell you a story. I'll tell you a very, very interesting story. At the American Urology Association meeting, it's like a science fair. So they have big lectures with 1,000 doctors attending, and then there are rooms that for an hour at a day, they'll present different research studies. And the doctors, have their big poster, and the poster gets put on the wall, and the doctor stands in front of the poster, and everybody walks around and they ask questions of that doctor, right? And so that's where you get to see the hot new research. But it's also an area of schooling in a negative way, and that is they use it as an opportunity to show kind of stupid research, bad research, or just research that's not assessing the patient well. So there was this poor guy from somewhere in Eastern Europe who was presenting a paper in which he said the best way to treat Hunner's lesions was with Botox. And so they gave him a podium session. So not only did he stand in front of his poster, they then let him present his data to a room of 500 or 300 people, whoever was in the room at the time, knowing that it was going to provide a moment of education for everyone in that room. And so he presented his data. And then the top doctor in Europe stood up at the microphone and said, have you ever treated Hunner's lesions any other way? And he said, no. And he said, and the young researcher said no. And this European doctor just schooled him. I mean, he was as flat as a pancake after a couple of questions. And what Dr. Nordling said is, he said, when I treat my patients with Hunner's lesions correctly, the pain goes away in 85 to 90% of the patients. But you aren't even treating your lesions. So your patients are suffering. And then you're giving them a treatment that does nothing. And he basically said, how do you justify that? And the young doctor said, well, it's what we do. It's just what we do. And he said, well, maybe what you're doing is wrong. Why don't you go back to the basics and treat the lesion correctly? And this guy walked out of this seminar just hangdog. I mean, to have the top doctor in Europe just squish him like a bug. And it was done it wasn't, he didn't personally attack him. He was attacking more the procedures of the hospital. But it really resonated to me because he was really crystal clear that when you treat a lesion correctly, pain goes away in the vast majority of patients who use it. When you don't treat the lesion, that patient will continue to be in long-term chronic pain until that lesion is treated correctly. And so I think that it is important that you not walk away from getting those lesions checked, okay? And if there's, and yes, you're looking for doctors. What state are you in now?
Utah.
Utah. Well,
not many.
Yeah, somewhat slim pickings in Utah.
Yeah.
Keep looking. Again, you can print out the AUA guidelines. Say, listen, I'm here because I was told I had Hunner's lesions. I have had discomfort because of the Hunner's lesions. I'm here because I would like to have my lesions treated correctly according to the American Urology Association guidelines. Here are the guidelines. Here's a section. This is what I would like to talk with you about. Can we treat these lesions, at least with a steroid injection? If not a steroid injection, then maybe laser therapy or fulguration, provided they know how to do that. Okay.
Interesting. Okay.
Okay. All right,
That's
hon.
good
Well,
stuff to know.
and know too, listen, some of the medications that you're taking, like Cymbalta, are known for discontinuation syndromes. Do you know what that is? Do you know what a discontinuation syndrome is?
Never heard of it.
It means that when you get off of the medication, it is very, very hard on your body. And so, and the challenge with Cymbalta and Lyrica, and even there's an over-the-counter decongestant who does the exact same thing, is that normally when you go off medications, you gradually reduce the dose. But the last time I read about it, I think it was with Cymbalta, they didn't make a lower dose. And so you went from all to nothing. It was impossible to slowly reduce that patient until they could get to the point where they were off the meds. And so what it does is it triggers a discontinuation syndrome, which is it's not what's the right way to describe it? It's not well.
Not like withdrawals.
Well, it's not. That's a good comparison, but it is not withdrawals. It's a discontinuation syndrome where your body goes through potentially some really severe side effects. And so let's just say you have the hydrodistension, they treat the lesion, or maybe you don't even have lesions anymore. And they're like, hey, man, your bladder is actually doing really, really well. You then get to ask the question, do I really need all these meds? Because, paying for all these meds is expensive. And when you start having that discussion about what can I reduce first, you're going to really have to have a thoughtful discussion with them, do your research, understand that some of these are going to be a little bit harder to get off, but it's doable. But it's just going to take preparation and planning. Okay?
All right.
All right,
good.
Hey, man, we're in it together. We're in it together.
Yeah.
Okay, hon.
Good talk to you.
Nice talking with you. Oh, Guadalupe. Guadalupe is here. Okay, but Guadalupe, I cannot hear you. Can you say something, Guadalupe? I can't hear you at all. You are unmuted. Do you have a headset?
Yeah.
There you go. Now I can hear you. How are you, hon? How are you feeling today?
I'm feeling okay. It's been kind of hard. I just recently got diagnosed, so it's been a new journey for me.
Okay.
I'm 32.
Okay.
I have 4 boys, twin boys. They're 3, so it's really hard to take in this new diagnosis.
Okay.
Especially with COVID-19, I haven't been working. I got diagnosed a month before lockdown, so I'm getting ready to go back to work in 2 weeks, which I'm really nervous. Mostly on my symptoms, it's mostly frequency. I've been trying to do diet change. I haven't been taking any supplements or any medication.
Okay.
It doesn't seem, I don't get a lot of pain, which I'm grateful for that.
Okay.
I just see how a lot of people suffer for pain.
Okay, honey,
I just want to.
Could you do me a favor? Can you lift your phone up a little bit? There you go. Now I can see your whole face. Okay. Okay. So let me repeat what I think you said. So you've just been diagnosed. You have 4 children. You're having frequency, not a lot of pain. You're not sure what to do next, right?
Correct.
Okay. So when did your symptoms start?
Well, my symptoms have been kind of on and off, but this last January, that's when it started, where I started having pressure. I went to see the urologist. She did a cystoscopy. She told me that the only thing she saw was inflammation in my bladder. She thought I had a mild case of IC.
Okay, good. I like that.
She said you could start off by doing diet modification or start taking Emeron once a day, which after reading all the side effects, I decided not to try it.
Okay.
I'm in California, so I just recently spoke to her via phone, and I asked to see if I could refer for a second opinion for another urologist, which I'm waiting to see if that gets approved through my insurance.
Okay, but why do you want a second opinion? I don't understand. I mean, she said your bladder looks pretty good, that you've got inflammation. So what are you worried about? That you're getting a second opinion?
I just want to see if there's a different treatment. Because when she said Emeron once a day, I started looking around and it said it was taken 3 times a day. So I don't know if there's different options for me. I usually just urinate 8 to 10 times a day.
Okay, so your case is quite mild. Okay, and how old are you again?
I'm 32.
Okay, so I don't know if you watch my video on subtypes that we know that there are different variations of IC. You know, not everybody's the same, right? You understand that, right?
Yes.
So some people it can begin in childhood, others it can be after menopause. For some people it begins after having a baby, while for other people it can begin because they have an absolutely terrible diet. So there's lots of different reasons why the bladder can give you or why you can have symptoms of frequency, urgency, pressure, pain. So the good news here is that she looked in your bladder and your bladder actually it did not show any severe dysfunction. So that's wonderful. The good news here is that you're only urinating 8 to 10 times a day, which again also tells me that your bladder wall itself is probably in pretty good shape. But so let me ask you a couple of questions. When you try to urinate, can you start your stream right away or do you hesitate?
I can start it right away.
Okay. Is sex painful?
No.
Okay. When you sit down, do you have pain?
No.
When is the pain the worst? At night or during the day?
Really, I haven't experienced much pain.
Okay. When are your symptoms the worst? Morning, noon, night?
Usually, mostly it's in the morning with the frequency.
Okay. Are you diet sensitive when you eat certain foods? Does it get much worse?
That's what I'm trying to figure out because since I was diagnosed, my frequency hasn't really gone away even with the diet change.
Okay. Do you have a pulling or a pushing sensation in your pelvis? You ever feel
just the pressure?
Okay. When was your last baby born?
My twins were born 3 years ago.
Woo, you carried twins. Congratulations. Now they're twin toddlers. Oh boy. Yeah. So, you have to understand that there are certain muscles that will give you frequency urgency. It's not, even though you've got what you think are bladder symptoms, they can actually also be muscle symptoms. And so when you had your twins, for example, did you suffer any muscle tears?
Well, when I was put on bed rest because they said my I can't remember what my service was shortening, they said. So I had a C-section, via C-section, but there was no tear.
Okay. So you had a C-section. Is your scar tender when you touch your scar?
It just depends.
Well,
Depends, like, if it's
okay,
very active.
so that's actually kind of important. And in fact, it's this book. Hold on a sec. This book, Ending Female Pelvic Pain, has a whole section on scars and how scar sensitivity is real and can. Oh, look, I just turned it right to it. Look at that. That is so crazy. So that in some patients who have had C-sections, let's see. Well, let me just do it. Hold on a sec. Let me just get to the first part of this. Post-surgical scar adhesions occur in women after most pelvic abdominal C-section surgeries. The fibrous bands that form during the healing process post-surgery often cause tissues to grow together that would normally not be connected. In my experience, the longer a woman waits to seek therapy for her scars, the denser and tougher the scar adhesions become. I have seen women develop pelvic and sexual pain as a result of abdominal surgeries for fibroids, hysterectomy, C-sections, and endo. And she says new mothers are one group of women that tend to be overlooked. Let's see, hold on. Another group of women that are overlooked are people who have had C-sections. Statistics show that over 31% of births in the US are by C-section. Make no mistake, a C-section is a major surgery. Adhesions, pelvic, and sexual pain are often a direct result of scars that have been bound down. So women who have experienced any of the above surgical procedures will benefit from stretching and mobilizing their scars to prevent adhesions. Anyway, you know, we talk about trauma, we talk about traumas, and how for many patients, there's a series of traumas over time. Well, you have had traumas over time. You know, you've had 3 pregnancies, including twins. Your pelvis today is not the pelvis that you had when you were younger, before you had children. Things have changed. Muscles have stretched out, things have changed, you know, and now you have scar tissue. And so I think it'd be really interesting to have a pelvic floor assessment just to see what the health of your pelvic floor is. And at the same time, you've got to talk to them about your scar tissue and if that's sensitive, because that could be a kind of a what's the right word? It's not red herring. The devil is in the details here. It's often the little subtle symptom. It's the little subtle symptom that patients often ignore that often helps figure out what the fundamental problem is. And so it doesn't sound like your bladder wall is to any great degree compromised if you're only peeing 8 to 10 times a day. If you had a really severe bladder wall injury, you'd be peeing 50 times a day. You'd be peeing every 10 minutes. So I think that that's good news, is that your bladder itself looks to be pretty good. I just don't want you to walk away from what makes a little bit more sense in your case, which is you just carried twins, you had surgery. Could your pain be a legacy of that surgery? Could your pain be a legacy of some muscle issues? It's possible, and it's probable at your age. But I guess the other thing is again, you know, your bladder wall was inflamed. So how was your diet? Was your diet pretty good or was it pretty bad?
No, it wasn't good. It was bad.
Okay, so you know, you could definitely have sustained. I mean, it could be both. You could have this underlying muscle dysfunction that means that your bladder is being deprived of blood flow to a certain degree, and then you know the straw that broke the camel's back was just your diet kind of sucked, and you kind of hit that point, right? Are you having normal periods?
Yeah, they're pretty heavy though.
See, that's interesting too. I mean, that's interesting too. So like, what's that all? I don't know what that's all about. But I think that it would be very interesting to actually go see a gynecologist or a urogynecologist and have them examine your pelvis and examine your
They
muscles.
actually did, Jill. Sorry. They did refer me to pelvic floor therapy. She said it didn't look bad, but she said that, you know, it was worth a try. She said to go see one.
Good.
So I'm waiting for that as well.
Good. I mean, I listen, hon, there's good news for your case. This is a good news situation. Whatever it is, you caught it early. And if it was diet triggered, you know, and that's kind of like, I see it's kind of like a reckoning. I mean, and when it hits, it forces you to confront, you know, bad food. And we've all done it. We've all been there. So you cleaning up your diet and creating an environment that will support your bladder is only going to help you in the long run. And I applaud you for that. And now we just have to try to figure out, you know, are the urethral diaphragm muscles tight to the point that they're giving you frequency urgency? And it's very, very possible. So at least go have that pelvic floor assessment and have them check it out. Okay.
Okay.
Yeah. And I would not be, listen, you're not peeing blood. You don't have pain. And so the great news about coming to a support group meeting like this is you get to see context here. And the context that I'm hoping that you're hearing is that compared to others, your situation is not alarming, and you should not be alarmed by this. You know, your body's talking to you. It's giving you a warning. It's saying, hey, man, I'm not happy with what's going on right now. We got to figure this out. But the good news here is I don't see an active disease process going on, right? I mean, that's what it sounds like. But again, we're all just guessing. I'm just guessing. Your doctor did say inflammation, but now let's just go have a really good proper pelvic floor assessment and see what they find.
Okay.
You know, and I just want to say that the reason why I'm emphasizing that is because there are some women who do bladder therapies for a decade and they never get better, only to discover after the fact it was all their muscles, that it was all their muscles. And so I don't want you to waste any time. Let's just start ruling stuff out. And I think that there's a pretty good chance that your symptoms might actually be muscular. Do you ever feel like you're carrying a bowling ball around in your pelvis? Do you feel a heavy sensation?
Sometimes, yeah.
Oh, okay, that's muscle. Or that could be what we talked about the first part of our meeting, which is pelvic congestion syndrome, where you've got kind of like varicose veins in your pelvis. And they tend to get fuller as the day goes on. So if you feel that heaviness and pressure as the day is going on, that sometimes could be pelvic congestion syndrome. So one of the two, okay? You keep us posted and let me know what they find.
Okay, thank you.
All right, hon. Nice talking with you. All right, guys, I need to go use the restroom real quick. I will, because I just drank a bunch of water. I will be right back. Pee break. Alrighty. Over there. So hold on a sec here. YouTube, my friends. Hello, Denise. Denise says, good to see you. I'm having urethral pain since I was diagnosed with an E. coli infection, was put on macrobid. Yes, that is true that E. coli infections are somewhat notorious. Rita says, my bladder does not stop spasming. What do I do? So you have to remember that you've got two different types of muscles in your pelvis. You have got the smooth muscle of your bladder wall compared to the skeletal muscle of your pelvic floor. They are different types of muscle. So if you're having bladder spasms, you would be using a smooth muscle relaxant, which is normally ditropan, also known as oxybutynin or Detrol. You could also, another smooth muscle relaxant would be a chamomile herbal tea or peppermint herbal tea, but that's just really not going to, bladder. Listen, girl, if you're at the point where every time you pee and the last couple of drops are coming over, you're bending over and screaming because the spasm is so violent, chamomile herbal tea isn't going to do a damn thing. That's when you need ditropan or Detrol. And so you need to ask your doctor for potentially a medication. Muscle relaxant is going to be Valium, Flexeril, Baclofen, something like that. Denise says, aren't us sufferers fed up with stubborn doctors? Well, it's not that they're stubborn, it's that they're uneducated. And now that you get to be an ambassador for the IC movement. I always say that to everybody. It's like, seriously, you're an ambassador. So if you start yelling at your doctor, you're making the rest of us look pretty bad. On the other hand, if you can educate that doctor and give that doctor some of the latest information, that is like the best thing you can do. You're an ambassador. You could help the next person walking in. All right, Facebook. I'm coming back to Facebook here. Julie says, did the Microgen next generation urine test? Came back with no 7 Gardnerella vaginosis. Interesting. Had a cystoscopy 4 years ago. Biopsied 2 areas of tissue. Results had bladder lesions. Polyploid fragments of a largely denuded urothelium, which means your urothelium was pretty much didn't have any mucus on it. Extensive acute chronic inflammation. Okay, was given all the protocol meds with no results. Thinking now I have pelvic issues more, so the nerves, as you cannot sit or stand for any length of time. So Julie, girl, you're a mixed bag. I mean, anytime you can't sit or stand for any length of time, we're looking at muscles and nerves. If you have pain as soon as you sit down, we're looking at pudendal neuralgia. So the piece that's missing assessment, what's going on with your pelvic floor? That's what I would want to know. I mean, clearly your bladder wall is not in very good shape. Clearly you have inflammation. I would want to know too, do you have where something like cyclosporin might actually be very powerful? Norman says, I'm the lucky guy who has IC. I'm 65, came down with it when I was 25 for the last 10 years or so. I'm up every 2 hours and pain-free. Previous, it was every 20 minutes. Of course, the bladder is still shrunken, a legacy. Lucky to have had great family and friends. Founded a support group in the mid-'80s. Got a book out about what we learned. Cool. Norman, I think, are you in Texas? Because I seem to remember hearing about you. Christine said she had horrible withdrawals from Cymbalta. Right. Jennifer, be aware, I was fine with IC. I was fine with IC about 12 years ago until I was out on benzodiazepines as a treatment. And she says, I can tell you benzos, Valium, Xanax, Ativan, Klonopin can cause bladder pain and pelvic pain. You're healing. All right. Hello, Cindy. Jennifer, the brain injury, my bladder and pelvic floor is so much better now that I'm healing. Please research benzos. Yes. Rebecca says, I believe it's my muscles. Hello, Mary. Nice to see you. Mary says, I've been taking over Sister Project for over a week, and maybe it's coincidence, but I've been able to get through my mail route without any bathroom stops. Hallelujah, baby. Yeah. Yeah, that's what we like to hear. That's what we like to hear. You know, when I took bladder Sister Project, it felt like my bladder was filled with warm cotton candy. It was a good feeling. My challenge is that, at least with Sister Protect, I I started with 1 a day. I could do 1 a day just fine, but I could not do 2 a day. When I moved to 2 a day, it gave me loose bowels, and that did not work well for me. Okay, now I can scroll back with Facebook. What? All right, so let's go back to Zoom. All right, guys, you know what I'm going to do is I'm going to shut down the Facebook and the YouTube, and we're just going to be on Zoom for the last couple of things. I am posting the link. Hello, Shotzi. Nice to see you. Shotzi says, I had inflammation in the lower trigon of my bladder causing urgency pain, very heavy periods, hormone replacement therapy, and pelvic floor physical therapy changed everything. Yeah, baby. Yeah, that's what we like to hear. All right. So I'm putting in the Zoom invite one last time on Facebook. And the and the password. And I'm going to say goodbye to Facebook. All right, Facebook, hello, or goodbye, Facebook. All right, YouTube. I'm going to keep YouTube up a little bit longer. All right. Okay, let's go back to Zoom. There are still some of you that I have not talked to. You guys, I'm just basically, I don't have any specific order. I'm just, and Allison and iPhone, a couple more in there. All right, so who have I missed? Who have I missed? Sue? Sherry? Okay, here, hold on a sec. Allison, I gotta mute Allison there for a moment. I see you. Hi, Allison. Okay, I will unmute you in a second. You just came in. I'm gonna go to Sherry first, okay? Sherry? Sherry.
Hello.
Hello, Sherry. How are you doing today, hon?
Much better.
Woohoo! Yeah!
I started out the meeting last week feeling pretty good, and then halfway through it, I started feeling really bad.
Yeah.
I had to lie down.
Yeah.
But so far, so good right now.
Awesome. Love to hear it. Love to hear it. You got any questions?
No, not really. I'm pretty stable right now. Because of the pandemic, I hadn't been able to go into the office of the doctor's office to give a urine sample.
Okay.
So they haven't raised my pain medication. I am on pain medication. That's why I'm feeling good. But I don't have that ecstasy feeling. I'm not feeling that good.
Yeah.
Bad.
Well, I mean, the purpose, you're using pain medicine correctly if you're using pain medicine so that you can function. I mean,
Yeah.
if it helps you get what you need to get done during the day, then that's the right reason to use pain meds.
Right, and they're weaning me off of the hydrocodone, the Norco, and they're upping it's called buprenorphine.
Okay.
And so they haven't been able to raise it in 2 months. So I'm on like 2 milligrams, 10 hours a day. So whenever they get another sample from me, they can verify that I'm not taking any other drugs, and then they can raise that and then lower the hydrocodone more. So they'll lower it again.
Okay, and so then it is always important in this context to ask ourselves what is causing the pain in the first place.
I believe it's pelvic floor dysfunction.
Okay.
And I had a hydrodistension, and it ruled out Hunter's lesions this last time, but I've had them before.
Okay.
So I guess there's my bird. Sorry. She decided to come see me. But anyway, right now I'm good with that. I still have, a lot of burning pain and just pelvic floor pain.
Okay.
And I think it's from childbirth, having my daughter. I just about pushed everything out of me. I know I had a prolapse in my uterus and my bladder.
Oh, well, girl, yeah, that's huge. That's huge. The fact that you had a prolapse, a bladder prolapse and a vaginal I mean, so what are you doing about your muscles?
Nothing, because I was going to start the physical therapy.
Oh, right. Okay.
And that's when we had 2 months ago. I've been locked down since March 12th. So I've not been out.
And you keep staying. Everybody, seriously, everybody here, stay home.
Yeah, I've been trying. I've been doing good.
Regardless of what the idiots are saying,
It actually helps to have pain, because then you don't have to convince yourself that you want to go out.
Well, yeah, it is weird, but seriously, have you gotten this book yet?
Yeah, I want it.
Okay, have you read it? Have you read it?
I've been reading it. Yeah.
All right.
You sent it to me. Yeah.
So when you go, what I really want you to do is I want you to think about the injury that you had in childbirth, and really try to focus on where you think in your pelvis you were injured. Okay.
Okay.
Because that ultimately, in the end, is your ability to kind of present the scenario. It's like, okay, doctor, listen. Or the physical therapist. When I had my child, this happened, and I have been in pain since then. Oh, your bird is hysterical.
She's trying to chew on my clothes.
I think this is hysterical.
I have holes in my shoulder, my little pajamas here.
The other thing that to me is interesting is, do you feel better on a muscle relaxant? Do you feel better on a muscle relaxant?
Not right now, because of the fact that I'm taking the 2 pain medications, even though they're low dose. The muscle relaxant, taking tinzanidine, but it makes me too drowsy, so I haven't been taking it.
Well, okay. So again, you can't put the cart before the horse. It's not helpful to just keep treating the pain if you're not also treating the cause of the pain.
Oh, I get it. I get it. Yeah. So
because if you treat the cause of the pain, you might not need the pain meds.
Right. Maybe I should back off and give it a chance, because
I mean, clearly the doctor gave it to you for a reason.
Yeah.
Right? He gave it to you, but you're letting the pain distract you from the intention, and the intention here is to try to resolve the source of the pain.
Okay. And I use an alarm clock, so I don't take it too soon. I take it, like I keep track of it.
Yeah.
My pain medicine. And so maybe what I should do is incorporate the muscle relaxer in with it.
Well, you have to do exactly what your doctor told you to do. And you got to talk to your doctor, talk to your pharmacist about the correct way to use them. What I'm just trying to point out to you here is that you can't put the cart before the horse. Pain is the symptom. Okay. It is not the problem. The problem may be the muscles. And so your first priority should always be to work on the muscles. Here,
is there an anti-inflammatory in with the pain medication? I mean, the muscle relaxer?
Not necessarily. Mary looked like she had something that she wanted to contribute to the discussion. Mary, did you just nod your head? Did you have something you wanted to say about that? Mary Lasher?
Oh.
Okay.
Oh. Okay. Well, yeah, maybe you've given me something to think about.
Okay. Think about it. I mean, I just going to say that I do encounter this fairly frequently, and that is, and I understand it, because I had terrible pain for a year, and suffering is suffering. It is suffering. And to be able to have an hour without pain, a day without pain, is so important to your mental and emotional health.
I haven't had that in 10 years or more.
Okay. So the important thing here, though, is we always have to, when we get past that point, now you can control the pain. Now you know
Mhm.
that there are medications that can control it. So now
Yes.
that you have that confidence, now we can go one step further and go, all right, so now let's try to figure out what's triggering the pain in the first place. So you
Okay.
don't have to use
Yeah.
all these meds, right?
I should do. I'm just scared of being drowsy. I don't like taking medication. Period.
Well, you ask about dosage, correct use. Can you use less? Can you use, you have to talk with a pharmacist about it and your doctor about it. Okay.
Okay.
Okay,
Okay.
hon.
Sounds good.
All right.
Thank you.
You're very welcome. All
Let
right.
me ask you this, Jill.
Yeah.
Are the people still? Well, you said you kept YouTube on. Are they in silence or asking questions or?
They're asking questions, so I'm still occasionally doing answers, but not very many. I was kind of
Okay, but
I was doing all three platforms for a moment there when you
I
saw me
know. I was
looking
gonna say,
down.
how do they know you're talking to one group and another? So
Yeah, it's crazy.
you are doing it. I
Yeah,
can
I'm
tell.
trying.
You're making it work out.
I'm trying. All right, hon. Thank you.
Okay.
Okay, so I'm gonna go. Okay. Hold on a sec. Allison, I know I have you, and I think Mary, I know I have you. Allison, you came in first, so I'm going to go to Allison first, then I'm going to go to Mary, okay? So let me unmute you. It takes a minute.
Okay.
There you go. Hello there, hon. How are you today?
I'm okay. I mean, I feel like I'm a little different because I feel like I've had it my whole life. I don't have any recollection of being normal. So I'm in pain, but I'm relaxed.
Okay.
Can you hear me?
Yeah, I can hear you. No, I
Okay.
just had to mute Sherry.
Yeah.
Okay.
Yes. So I've always thought it was bladder wall for me, but recently I've been working with a physical therapist who's wonderful. And
Okay.
so I believe she's gotten really worked with the fascia and the muscles, and that's all good. But now I have a lot of tightness in my back, which connects to the scrotum, so she's working with all of that. I know I have nerve involvement on the left side. And when I go to the restroom, when I pee, I could empty and then have to pee again right away.
Mm-hmm.
Like the next drop, I feel the drops kind of almost like that.
Mm-hmm.
There is a relief, but I feel, and so it's worse in the morning, always, 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 better at the end of the day or in the middle of the day. So I'm just always trying to do things to help it. And right now, my hope is that as continue to work with the physical therapist,
Good.
will help. But it's just, I think it's a combination of things. And I've been listening to you question people. I do hesitate when I go. I don't, it's not immediate. I have to concentrate.
Okay, so that's your muscles. If you have to concentrate to pee, if it takes time for you, normally when you pee, a muscle relaxes, a sphincter opens, and you pee, and it's instantaneous. Right. If you can't do that, that means your muscles are in all likelihood quite tight. And I mean, how old do you think you were when you first had symptoms?
I think I had symptoms as a child, and I thought it wasn't until I got to college. And of course, I'm almost 60 now. But when I got to college, and people were like, "No, it doesn't hurt." I always thought it hurt when you had to pee. And then someone told me also that this is what it feels like when urine's in your bladder, and they went like that, and I'm like, really? Like that? Like just like that's no pain, right? So I don't ever recall it not hurting when I had to pee.
Okay, so does it hurt as your bladder fills with urine, or does it hurt when you're trying to pee?
No, when it's filled with urine. So when I empty, there's a relief. However, I'm sometimes very sensitive to the next. Like I feel like I think I can be very sensitive to just a tiny, tiny bit in my bladder. So I could empty completely and then feel the next drops coming in and have to go again. And so I think there's my urethra, like the nerve is turned on or something. Like the nerve is.
Has it always been that way, or is that more recent?
No, always.
So, a lot of the symptoms that you've described, we see in older folks. Especially, I call it milking the bladder, where you pee and then you stop and you think you're done. And it's like, no, I feel something there. And you pee and you get a drop and then you stop and you're like, okay, I think I'm done. Then you stand up and you go, nope, not done. You sit back down, you get a little bit more. And when I talk to my gynecologist about that, he goes, yeah, we see that all the time in a woman who is perimenopausal or menopausal, because the muscle is basically getting weaker with the loss of estrogen.
Mm-hmm.
So when we go back, but see, the thing is that for you, it happened from when you were very young. And so do you have scoliosis?
No.
Do you have one leg longer than the other?
No.
Do you walk normally? Do you limp or do you walk normally?
I think I walk normally.
Do you have any foot problems?
Yes. I used to be a runner, like, for many years. And I do have, right now I have, on my left foot, I have a metatarsal issue, and I'm getting treatment for it. They just are revising my orthotic. I did check. I have the Morton's toe, and I have them, and they were just like, yeah, no, you're fine with, like, they didn't really, podiatrists didn't think anything of that. So yeah, I do have a little bit on the left side.
So, you know, what they often say about children, let's say somebody in elementary school has frequency urgency, they will often say, well, they'll just grow out of it. You know, they'll just grow out of it. It's just a childhood thing, right? And that's sad, because that's really not fair to the child. It's not really giving that child any tips on what to do, or their family members. But it makes me think of two things, because I had frequency urgency in 7th and 8th grade. I couldn't sit through class. I also had scoliosis. I mean, at my first bladder examination, they discovered I had scoliosis. So it was literally within a month or two of me developing scoliosis that I had frequency urgency for the first time. So, you know, that helps us focus on muscle. Was there some sort of abnormal muscle development? Was there an imbalance? Were you pigeon-toed? Were you duck-feeted? Was there a fundamental shortness with one leg or the other? You know, we do have to consider the mechanics of the human body. And was there a mechanical dysfunction from day one? Even a birth defect. I've got one friend who comes on occasionally who, now in her case was really interesting, because she could not run. You know how when you're in elementary school, they have you run around the track? Remember, for our generation, we had the presidential physical fitness exam. Remember that? And they would have us do pull-ups, and we'd have to run around the thing. She has never been able to run without leaking. Never.
Oh.
So even when she was a child, she could not run. And they only discovered after the fact, when she was in her 40s, she developed total incontinence out of the blue. Just bam, totally incontinent. When they went in, she had a birth defect. It was a birth defect. And,
well,
you know.
And I've asked my mom, she's 85 now, but I've asked her, would I have any injuries? No. The only thing which I think could be significant or could be not, when I was 4 months old, I had pneumonia. I was in the hospital. I had antibiotics. So I was like, okay, could that have triggered something? I don't know. I really don't. But she says there's no injuries that, you know, out of the ordinary, nothing. So yeah, it's kind of a puzzle to me. I don't really know why. What it is. I always kind of think it's that bladder wall, though, because it's so uncomfortable to hold the urine.
Right.
But there's got to be something with that nerve, because why would you feel like you had to go right?
Well, I think you've got central sensitives. I mean, you've got sensitization down there. One nerve got involved, and we know that when one nerve gets sensitive, other nerves in the area can also become quite sensitive. And so I have what I call rectodynia, where my rectum is very, very sensitive. And if there's anything in there, it drives me crazy. Yeah. So you're kind of describing the same thing with your urethra.
So what I'm wondering too is, because now as we've worked on the body a lot, now I'm noticing when I do my back exercises, my tension is really on the left leg as you go down the leg. And I know, so I wanted to ask my physical therapist at the next appointment, like, okay, how does that connect anywhere that would lead back to issues? Because we haven't really worked on that leg. Because anytime I do anything, that's kind of where I feel the tension. So I don't know if if working on that area would help, or
you got to follow every path, hon. You got to follow every path. This could be something as simple as, maybe your mom had you wearing weird shoes when you were growing up that just created this really weird balance. I mean, it's hard to say. I mean, so you're never going to know. You can't agonize over it trying to figure it out. Whatever happened, happened. So all you can do at this point in time is focus on today. What can we do today to make you feel better? Yeah. And so concept number 1 is the health of your muscles. Concept number 2 is the quality and health of your skin. And now that you're older, you got to be on top of estrogen atrophy, because it is going to happen. It is going to happen. And so, paying attention to that health down there. And if you feel better with a bladder coating, then power to you. Do the bladder coating. I guess the other thing I would do is I would just go through that list of other conditions and just make sure a Tarlov cyst off of your spine. I mean, it would be interesting to kind of just, what do the AUA guidelines say? The AUA guidelines say if a patient is not responding to therapy, or if a patient is getting worse rather than better, take a step back, revisit the diagnosis, and let's make sure we know what we're treating. Right? We need to know what we're treating here. And so I don't have a problem with you going and having a CAT scan. I mean, a CAT scan of your pelvis or an MRI of your pelvis to look for, anything weird. It's an anatomical mystery. I worked with one lady, and I've told this story before. So your urethra is about the size of your little finger. She had a fistula right next to her urethra with a little tiny tube connecting them. And so in the fistula, and who knows why it happened? I had no idea. She could have been born with it for all we know. It was the fistula that was causing the pain. She kept having urethral pain. It's like, guys, it's always here. It's always here. It's always right in this area. And they all blew her off until a nurse practitioner went, oh, that's weird. Let's do a CAT scan, or whatever it was, CAT scan or MRI. And they found this perfectly sized twin fistula. And when they removed it surgically, she was healed. Wow. It was the fistula that was the problem.
Yeah.
So, I don't have a problem with going back and saying, I want a second look. I want a third look. I mean, this has been going on for a long time. We've never looked at this. Can we explore this? Right?
Yeah.
Squeaky wheel gets a grease, dear. Squeaky wheel gets a grease.
No, I feel like I've been trying to be a detective all these years. Try this theory, try that theory, try this. I did the next gen. I did like every step. So I really appreciate all the information you bring, and reading. Do supplements. I do, all that stuff. I was on Elmeron, but it never really stuck, and I'm so happy for that now that I just wasn't that because the eye damage. So, but I'd like to do things more naturally, anyways. So
right. I guess the other thing to ponder is just the concept of nerve sensitivity. I mean, were you born sensitive like I was? I mean, do you have super sensitive skin?
No.
Okay. Can you wear wool?
Yeah, I could. Yeah.
Okay.
Maybe not now since menopause. I don't know. It'd probably be too hot, but yeah.
Okay.
But yeah.
Well, the hallmark of central sensitization is having super sensitive skin, being drug sensitive, where a normal dose of a medication is often too strong. We have to take half doses, baby doses. We're afraid to try stuff because we don't know if we're going to have side effects or not. We tend to be food intolerant. There are some foods that just don't work for us. And it's not just our bladder, our body. For me, it's oatmeal and chocolate just destroy me. We tend to have chemical sensitivity, where if there are chemicals in our home, they really make us sick. We have a wicked sense of smell. We smell things that other people cannot smell, and smells really drive us crazy sometimes. Like something everybody else is used to, for us, it's like, it's weird that a smell would provoke pain, but it does. Smells provoke pain and discomfort for us. Like literally running out of the room, gasping for breath, little tiny thing. So it doesn't sound like you've got the central sensitization. So it sounds like it's more of a muscle issue. I guess the other thing would be, and I hate to say it, but I'm going to say it. When we look at childhood things, we always have to consider the possibility of were you ever abused as a child? I hate to bring it up, but or were you dropped as a child accidentally on your tailbone when you were a baby? You know, your mom might not remember anything, but
I know.
you know, and or she might, I mean, especially at her age, she's not going to remember anything. I mean,
I did have tailbone issues in high school. I had to sit on a tube for like a few months. Like, you know, that red tube was real embarrassing. And we don't know how that happened. And
okay. See, that's huge.
okay.
That's huge right there.
Okay.
So if I were to, now remember, it's a guess, but,
right.
But I think a reasonable scenario, since you're not showing the central sensitization and the other stuff, is I'm going to bet that at some point in time, you might have been dropped as a baby and sustained a little injury. And it might have been very, very small. But remember, what we see are recurring injuries, little tiny recurring injuries that set the stage. And the fact that you had a tailbone issue in high school is really interesting to me, because it's the tailbone injuries that we see most consistently in people whose symptoms began after a trauma. And so, I mean, I don't know. I mean, I'm guessing here. We're all guessing, and you can't feel about it. You can't feel bad about it, and you can't have your mom feel bad about it or anything like that. It is what it is. At some point in time, some sort of traumatic event occurred. And, you know, it might, I mean, we just don't know. But what the gift that we have now, our physical therapists are so well trained in this, they're going to be able to dot the I's and cross the T's and try to follow things down. And so I tell her you had the tailbone injury, and it'd be really interesting. And that's another reason why an X-ray might be interesting, because is your tailbone out of position? You know, is your tailbone to the left? Is it to the right? Does it not have the right arc? Because your tailbone should be slightly arced outwards. Is it bent down? That could all explain, you know, long-standing issues. So, okay.
Thank you so much. Give me a lot to think about.
You're very welcome. All right. Have a good one. I love your background.
Yeah, I just did it by itself. I don't know. I mean, I have different pictures on my phone. I'm like, oh, okay. I'm not good with this stuff, but anyways.
The joys of technology. Yeah. All right. Okay. So, and then the lady I was just going to go to next has disappeared. Lisa, I did you, Lisa, and I did you, Heidi. Did I do you, Linnea? Oh, girl, you're the first one in the room. I'm so sorry. Okay, wait, I can't hear you.
That's okay. I'm learning so much.
Well, I mean, this is, I think, fun, because you're really having an opportunity to see kind of this detective work that I do with patients who call. And what I really like about today is that here we have two women where clearly estrogen is playing a role. And then with our last one, we had, and see, you guys, so you know, me with perimenopause is names. Bam! I rarely remember names, so I apologize if I forget names. It's just, I've been that way my whole life. But here now we have somebody who from childhood would having issues. And then, of course,
me too.
You know, of course, we have Laura, who is in Colombia, whose symptoms started, you know, when she was in her 20s. And so that is showing here this really rich and robust diversity that the medical system has to accept and embrace. We cannot put everybody in the same group. We just can't do it. And what a tragedy is that when you have a postmenopausal woman developing symptoms, that you have a doctor who doesn't even educate her about what aging does to the bladder and the urinary tract, and ends up kind of blaming it on her. It's just we're getting better, but we have so much work to be doing. So how are you feeling today?
Today's okay. The glucosamine is helping, and except for today, I've been pretty adherent on the diet. I'm starting to realize that just from listening to you, that some of the things that have been bothering me are because I had a injury to my coccyx. I had a Bartholin cyst that I had surgery on, and I was asleep on the gurney. My friend was in the room, and they pulled me onto the bed and tore out my catheter. And so some of these, and I'm a highly sensitive person. Since I was really young, couldn't eat orange pop. My parents figured out in the 60s, couldn't have pistachio ice cream because of the red dye. So there's a
no bubble baths, right? No bubble baths, right?
No bubble baths.
No.
That's right. I could not have a bubble bath, and cannot use the chemicals in my house. I've been able to eliminate certain things that, but I also have a collagen disorder, Ehlers-Danlos hypermobility. So, oh, okay, Heidi, we'll talk. So, I had pelvic inflammatory disease when I was in Japan, and they gave me an antibiotic before they tested for a pathogen. So I'll never know why. But when the irritable bowel causes inflammation, and then the pelvic inflammatory disease causes inflammation, and then the bladder, I've gone through periods where I couldn't even ride in the car. It was so painful.
So okay, so this is how I look at it, because your case is somewhat similar to mine. Okay, and that is the landscape of our bodies. The landscape of our bodies, the day-to-day reality is that we are sensitive, and we were born sensitive. Okay, it is what it is. We were, some people are meant to be trial attorneys and orthopedic surgeons. Other people are meant to be writers and artists. Some people are comfortable in the big, right, yeah. And some people are comfortable being in the big city. Other people are much more comfortable in the country. Some people love crowds. Other people, like myself, no, I don't really like crowds that much. I like being in a quieter environment, and it's so interesting. I say this to people frequently, especially when you're in your 20s, is that it's not just about finding a career that works with you mentally and intellectually. It's about finding a career that works for you physically.
I had to stop. Actually, they illegally let me go on the Bloodmobile in Southern California because they were trying to get the union in while I was on a leave of absence because my dad died suddenly. I was helping take care of my mom, but I have no income because of this COVID. So I'm gonna, for the first time ever, I'm gonna sell some of my photography. But yes, we have to be creative. We have to retrain. We have to be persistent, and we have to be tenacious.
And also really respecting the environment in which you thrive. I mean, that understanding that trying to push it when you know where your body is the most comfortable is always potentially going to trigger more pain and more, not pain, but just stress. It's just not comfortable. It's irritating. If I had to go to work in a factory that had a strong smell, I don't think I could do it.
It was horrible. They kept putting this thing in the donor center at the Bloodmobile in my division, and they kept putting this air freshener in the bathroom, and it would just make me sick, and I kept throwing it out. It had batteries. Take the battery out.
Right.
Just to survive.
Yeah. So, okay. So the sensitivity is the foundation. It's the landscape. It's your reality. It's my reality. It's not a disease. It is what it is. It's a gift of our ancestors.
I have muscle problems too. I have the trauma from that surgery.
Right.
And you know what? I have those ones. I cannot, we'll have to talk because
it's listen, I didn't get it for 2 years. I had it for 2 years. And whenever I tried to use it, I felt like I just didn't know what the hell I was doing at all. And it wasn't until I read, this book, The Breaking Through Chronic Pelvic Pain. And one of the things that he said in here really resonated with me because he said, think of a 3-sided box. Your pelvis is a 3-sided box. It's got a base and it's got sides and a back side, but there's nothing on the front, right? So it's a 3-sided box facing outwards. And one of the challenges here is that when you think pelvic floor, you think flat muscles. I mean, you're thinking it's a floor, it's a flat, that when you're sitting, it's flat. When in actuality, you've got lower muscles that go from low to right, and there's a couple of muscle groups. You have 2 different muscle groups that go from front to back. But then you've got muscles that go up the sides and muscles that cross the sides. And so my physical therapist kept saying, do a J shape. And you're laying on your back with this going, what the hell is a J shape? You just stick it in there and push stuff, right? It didn't make sense to follow the path of the muscle until I read the book.
Oh.
And the red book finally helped me figure it out and visualize what I was doing. And now I can do a J shape where I start low, kind of start on the bottom side of my vagina, and then I just kind of go upwards. And so all I can say is I think the book helps you visualize it a little bit more.
Okay. I have I'm on hormone replacement therapy now for the osteoporosis. So I think now I can actually not be so tender and I can start to do some interventions for myself. So I feel empowered.
Yeah. And that'll help. Let me just show you a couple of pictures here real quick.
Okay. See if I can take a screenshot since right now, I mean, I'm really tight with money because of this.
Well, you can find, all you gotta do is go over to YouTube or just go to Pelvic Health Rehab. There's some good physical therapists who do blogs who've got all this on their website.
Right.
But let me just see. Okay. So, you've got 3 layers of muscles. So the bottom layer, the flat layer, is this layer. This composes the levator ani. So you've got, this is the front of your body here, the back of your body, your tailbone here.
Yep.
And you can see, look, you've got 2 muscles, both sides, that go along the base and end up connecting to your coccyx. And then you've got a muscle here and a muscle here and a muscle here and a muscle here. But they're all considered part of the levator ani muscle, okay? So that is the bottom muscles. Those are the shallowest muscles. They're the muscles right underneath the surface of your skin. But then, let's see. I want to try to get... Okay, the next group of muscles are the perineal muscles. And so these are the mid-length muscles. And anyway, I don't really have anything to say about those muscles right now. The urogenital triangle.
Okay.
But the muscle, the deepest muscles are these muscles. These are the piriformis muscle.
Okay.
Okay, and here's the J shape. See the J shape?
Yep.
There it is right there.
I get it.
And so what's interesting, that's the obturator, is that when you have pelvic floor physical therapy, what's so fascinating is that their finger will hit your hip bone. They will be able to go all the way over to your hip bone and go up the insides of both hip bones. And that's the J shape, kind of, sort of. Those are the muscles that kind of go up that way. At least that's the best way that I can describe it there. And so when you understand where they are, it makes using, then you start with the wand. What I did is I went shallow first. I just tried to visualize and see what I could feel with respect to the muscle groups. Then I went mid-level, and then I went deeper. And what I find really interesting is that my left side triggers the most pain. On a day-to-day basis, I have more pain in my left butt cheek. But when I do my internal work, it's the upper right side that is the most tender.
Okay.
Because one side is compensating for the other side. The right side is being super tight because it's compensating for the weak muscles on the left side.
I have scoliosis mildly, and I have had sciatica, so I can see how maybe.
There you go. And I have scoliosis too.
And my mom did too.
Yeah, and so it's a S curve. I don't think you can see it. I don't know if you can see it with this dress, but let me bend over. Can you see that one side of my back?
Oh yes, I can see your rump is higher on one side. Yeah. Mine is so very minor.
Yeah.
But with the osteoporosis, I can tell things are getting.
Oh, that's what scares me, because I don't take calcium right now, and but I do. I mean, I'm trying, but I need to take calcium. The thought of having osteoporosis in addition to scoliosis is really not.
Oh, it's scary.
Yeah.
But I'll tell you what, if you could just take, there's this plant called the calcium plant. If you could just take a ton of greens, you just see, I've had a kidney stone. So it's like, oh.
Yeah, I have gastroparesis. I can't eat greens. They sit in my stomach for hours and start to ferment. So it's tricky.
Even if you cook them. Oh, God.
And I can cut them up really, really tiny. Doesn't matter. Same thing happens every time. I hate it. I hate greens. I'm so much better without them. It's ridiculous. So,
it's too bad too, because they're so.
So you and I were really sisters with respect to this. And then, hey, Laura, I want to come back to you for a second. I'm going to go ahead and mute you, because I want to go back to Laura, because she asked an important question here. So hold on a sec. Oh, you muted yourself. Thank you, Laura. Okay, I'm trying to unmute you. There you go. So Laura, you asked in chat, is lower back pain and sacral inflammation part of these symptoms? And the answer is yes. Yes. Tell me about your lower back pain and sacral pain.
I have lower back pains 2 years ago. It starts 2 years ago, and it's terrible. It's horrible. It's very painful, very, very painful, and I have inflammation in the sacrum.
Well, okay, so girl, what happened? Why did that happen? Do we know what triggered that low back pain?
No, I really, I don't know what triggers that. I know that if I sit for a long time, is worst. When I walk, is worst.
Okay, so this is an example of like the pivotal symptom here, because it absolutely points to you having a mechanical muscle abnormality as compared to a bladder issue. Because so the thing about the pelvic floor muscles is they go from low to high. Okay, they go from side to side, front to back, low to high. And there is a muscle called the psoas muscle. It's a big ropey muscle that anchors down in your pelvis and goes up both sides of your spine. And that's where I get spasms. I will get a very heavy, sharp. You can see me. We have these microwavable heating pads. No, I'm sorry. We've got these one-time use heating pads. and I will have 3 on going up the length of my psoas muscle.
Okay.
Do you remember, I mean, this is big, that you're having this sacral pain. Were you riding a bicycle? Do you remember falling on your tailbone? Anything at all like that?
No, really. When I moved like 2 years ago to the house that I live now,
Yeah.
it starts in that moment. Like
Were
it
you
really.
lifting heavy boxes?
Yes.
Okay,
Not so heavy, but heavy boxes. Yes.
so that may have been the triggering event right there. Is that you may have lifted something or something's improperly and strained some of your muscles. But the sacral pain is really interesting to me. Was it on the left side or the right side or centered in your body?
Is I feel like in the center, but when I have inflammation, it's more in the left side.
Okay, so I want to take back half of what I said to you earlier. You know, because seriously, hon, you are an injury patient. You are an injury patient. Your pelvic floor and your sacrum was injured badly. As you said, it was really bad. It hurt like hell. So you have to, you're just not understanding the influence there, that all of these muscles and your bladder in a small confined place. And if you've got a muscle over on this side messed up, then the muscles on this side are going to get messed up. And then you're going to have, you know, potentially muscle knots, trigger points, all sorts of stuff like that. I don't know what your medical care is like in Colombia. Did anybody ever do an x-ray or anything for your low back pain?
Yes, but all this is normal. I don't have nothing in the.
Well, okay, test. So the x-ray was normal. Did they do a side one? Is your tailbone in the correct position? Is it crooked? Is it straight when it's supposed to be crooked? Do we know?
It seems that all is normal.
Okay, but
like in the results.
Okay, but the thing is, hon, is you just said that you can't sit for long periods of time without having pain down there, right?
Yes.
Okay, so it's not normal. Something is abnormal. And it's either a bony structure, like your tailbone out of position, or it's a muscle that is not normal that is squeezing a nerve. And so you need to buy this book.
Yes.
You need to buy this book, and you really need to read it and try to embrace it, because you're at an age now where what you do now is going to influence the rest of your life. And I don't want you to walk away from your muscles at this point in time. We need to make sure that you did not sustain a muscle injury and a sacral injury, because I think you did. I think you did. And I think it might have been a couple of injuries over time, and then you moving was just the straw that broke the camel's back, you know, and really has messed up your muscles. But you need to tell every single doctor that you see about this, about your sacral pain and your low back pain. That is a critical symptom. It's way more important than the frequency urgency.
Okay. How normal is the thing of urgency and frequency? Because now, like with all the people that you interview, I think that I don't have like that urgency. Like I feel like eight or 10 times a day, but I take Lyrica, so I think it will help.
Well, but you know, normal. Everybody has their own normal, but you're certainly not over the top. And I mean, peeing 10 times a day. I see patients who'd be thrilled to be able to pee 10 times a day, right, ladies? You know, I mean, so your frequency is not particularly alarming to me. I mean, I think normal would be 6 times a day, you know, around there, like once every 2 or 3 hours. But you sustained an injury. And so whether it's your muscles or whether it's your nerves, you know, something happened here. And just that little bit of extra nerve sensitivity could explain why you're peeing more.
Okay.
Yeah. Yeah.
Okay,
So
thanks.
I think that you really, really, really need to follow this inquiry a little bit further and tell every doctor about your sacral pain and your lower back pain. I would want to know what the health of your low back muscles are. I would want to know the health of your core muscles. Is it your psoas muscle? I will tell you, with my psoas muscle, it zings me about once every 2 weeks. But man, when it zings me, it hurts. I've got to go get a heating pad, and I got to lay on that heating pad and really push it right into that muscle to get that muscle to relax. Okay?
Okay.
Okay.
Thank you.
And
It's
this book,
it's very important information for
yeah,
me.
this book is free on Kindle Unlimited. And which
Okay.
is they're basically their loan library. On regular Kindle, it's $9.99. We sell it for
Okay.
$26. If you want to pop me an email, I'm not sure if we ship to Colombia or not. But if you could send me an email, I will try to get an answer to that question. And I'll even, if I have an extra copy, I'll send you one as a gift. Okay.
Okay. Thank you.
Okay.
Thank
I mean, if I can do it, I will do it. But check your Kindle, and it's free on Kindle. If you can just do Kindle Unlimited, you can get it and start reading it tonight. But I just think that that's really, really, really important that we focus on that sacral pain. Okay.
Okay. Your email is IC Network.
IC Network at Mac, M as in Mary, A as in Apple, C as in Charlie.com. IC Network at Mac.com. All right.
Okay. Thank you.
Okay. And now hold on a second. I've got, we're about done. Chris says, what software are you using for to voice chat? We're using Zoom, Chris, Zoom. And we're just about done. So on that note, I think we're done. We've been going on for 4 hours now. Listen, we had 6 people here at the end of the day. I have got all of these old back issues of our magazine. And if none of you asked for any before, I'm sending people like 7, 8 old copies of our magazine, each of which has good articles. If you would like me to send you as a gift any of our magazines, all you need to do is, and if I haven't done it already, if you already signed up for it last week, I've already sent them out. I sent out 4 packets of 40 magazines. Send me an email with your mailing address, and I'll send you more, because I'm trying to get rid of them, and I don't want to recycle them, and I'm proud of them, and I think that they're good articles. Okay. Okay, guys, I'm going to go. I wish you well, and thanks for sticking out to the very end. All right. Bye-bye, you guys. Oh, you know what? I'm gonna, let's see. I'm gonna unmute Lisa. I'm gonna unmute
Bye.
Linnea, and I'm gonna unmute Heidi. Okay.
I'm going to connect with the other people in Michigan.
Hi.
Hi.
Hi, everyone.
Jill, I want some magazines, please.
Okay, just send me an email with your snail mail address. Everybody who wants them, just
Snail mail?
Yeah,
Okay.
snail mail.
That would be cool.
Except for Laura. Laura, if you want some, I'm not going to snail mail magazines to you, but I'd be happy to email you some magazines. Okay. All right.
You.
Okay, guys. I will see you later. Have a good one.
Thanks, Jill.
Thanks, Jill.
All right, Chris. Chris, I'm sorry you came in late. I will see you all later. All right, you guys. See you later. Everybody on YouTube, same thing. If you want any of our magazines, I've got a lot of old copies of our magazines that I'm trying to just give away. If you email me your snail mail address, I will throw some magazines in the mail to you. Okay, lots of them. All right. Okay, guys. I will see you later. Have a good one.